Okay. So once again, I would love to welcome all of you and a very, very good evening. So now let me share my screen. This is the PPT. What we are going to learn in these sessions are pelvic floor muscles and specifically male pelvic floor and male pelvic floor rehab for male pelvic floor conditions, dysfunctions. Whenever we are talking about pelvic floor, so this is a pelvic floor musculature. It's like a diaphragm. We are having the abdominal diaphragm. Same way we have a pelvic diaphragm. And pelvic diaphragm in this image, you can see this is the part which is connecting our pubic symphysis with the tailbone. So on the side section, if we'll view this muscle, you might see it's a very small kind of structure which is present. Unfortunately, this important structure is missed in our curriculum, and we were never taught that like how to help people who are suffering from weakness of this when the muscle is getting weaker or it is getting tight, some kind of incoordination happen to this muscle. So how to do assessment and rehabilitation, and we even don't have understanding about the depth of anatomy and physiology of this muscle also. And if I'll ask you one simple question that how many muscles are present into pelvic floor? So pelvic floor is a network of muscle. It's not one muscle. So my question to all of you, which you have to write down in the chat box, how many muscles are present, are creating pelvic floor? So all together. So can you please write it down, the answer? And the muscles in male body and the muscle in female body. If you have understanding, please write down that into the chat box. So let's start with this beautiful question and start getting learning. When we are saying about the pelvic floor and this small structure in this view from the lateral aspect, and if I'll show you into like that, so you can see it's quite a big muscle actually. It's not only why it's a small hammock shape, some structure. So that is a quite big muscle, and we know we all are aware about the pelvic cavity and pelvic bone. They are fused bone and coming together, and they are like joining with the sacrum at the back. And then we are also having sacrum is also joined with the coccyx. We all have understanding about that. And anteriorly, we have this two pelvic bones are joining together with the pubic symphysis, which is another connective tissue, very important structure. So on the top of this pubic bone, we have pubic symphysis. And on the top of pubic symphysis, we have in this pubic symphysis, you can see we have a skin. Then underneath the skin, we have subcutaneous tissues. We have a presence of glands, and then we can also see this appearance of hair into pubic hair into all this area. So those pubic hair are very healthy, shiny, curly, and into nature. It's because of the glands which is present into this whole pubic region. And same way, this is the pubic bone, and then we are having ischial rami going on downwards, and this is the ischial tuberosity both side, ischial sit bone, you can say. So now this muscle is coming all the way from pubic symphysis, is going back to the coccyx, and then it is also coming from this ischial tuberosity towards the center. So in this image, what you are able to see is only the one part of the pelvic floor muscle. So there are three layers of pelvic floor: superficial layer, then middle layer, and then we are having a deeper layer. So in this image, you can view the deeper layer, levator ani or endopelvic fascia. These are the different names of these inner muscles. So deep layer, endopelvic fascia, or it can be the levator ani or pelvic diaphragm. So four names are there. You might have heard about that pelvic floor muscle is a bowl-shaped muscle. So that bowl shape is given by the levator ani muscle, the deeper layer of pelvic floor. And onto this muscle, as we are saying, it's the endopelvic, like this, the pelvic diaphragm. So this muscle is separating, this muscle is coming in direct connection with the pelvic organs. So in a female body, we have three organs coming in from anterior to posterior. And in male body, we have two organs coming into from anterior to posterior. They're lying into the pelvic cavity. And these two organs are bladder of a male, and then behind the bladder we have a rectum of the male. and bladder is having urethra. So urethral canal is passing through this particular hiatus, this opening. So we call it as a hiatus, urogenital hiatus. So this urethra is coming from here, and then we are having another rectum, and rectum is having an anal canal that is passing through this anorectal hiatus or rectal hiatus, this one. Okay, so there are 2 openings in male and there are 3 openings in female, because in female we have another additional important structures which is making us unique. We can become mother. So that is the uterus, and uterus is having a vaginal canal. So that is also passing through that area. So let's understand this particular structure which is forming the base, the floor of our pelvic bone and the pelvic floor muscle. Like all other muscle of our body, this is again is a skeletal muscle, and we can voluntarily train if something happened to this muscle. Now what can happen? Any muscle of our body, they can go, like there are 3 property I will say. One is, like if I tell you to contract, or you want to hold something, so you can hold something in your hand. So holding, contracting, how much strength is there for this holding, what is the endurance of holding. So that this is all is the power of the muscle, how strongly the muscle can contract. And after this, how like in a best way it can relax. So relaxation is a very, very important component as well. So we always keep focusing on the contraction component, but relaxation is same way important. So contraction and relaxation, these are the 2 important functions of any muscle of our body. And the third function is the coordination with the brain. Whatever brain is sending the signal, the muscle has to act in that way. So coordination is also very, very important. So these are, if any muscle is behaving the right pattern and as per the command from the brain, contract, okay, relax, relax. So this coordination is also there, and the right time the coordination should happen. There are many reflexes are also present. So we are going to discuss everything. So same contraction problem, if the patient fail to create a contraction, so the muscle don't have a tone, we call it as a hypotone. Tone is less. So we hypotonus pelvic floor, and the dysfunction will be related to that. Muscle cannot hold, cannot contract. If it cannot hold something, you can say organ prolapse can happen. Organs can start falling downwards. If it cannot create a contraction around the canals, it might be, it will not be able to hold the urine, or not able to hold the gas, or not able to hold the feces. So incontinence dysfunction can happen, and that incontinence can happen of the urine as well as the feces as well. And same way, if it cannot create a strong kind of hold during the arousal or during that orgasm, during this erection phase in a male, so it can even affect the male like erection as well. The muscle should be strong enough to create a sustainable contraction around the base of the penis in male. So erection can be sustained and maintained for longer time period. So same way, the another function when we are talking about, if the muscle is having a high tone, so muscle don't, it's not a weak tone, it is having a high tone, hypertonus muscle. Those kind of muscles fail, they are contracted muscles, they fail to relax. So if they fail to relax, so we can understand this is going to give an issue to the person during voiding. So when they want to pass urine, there might be painful urination. They want to go for sexual activity, erection. So that will be, they might also feel pain during the erection stage. And when they will start their sexual activities, it might be pain during defecation. It might, the muscles which is supporting the anal canal, which is holding the anal canal, external anal sphincters, puborectalis muscle. So anismus can happen, puborectalis fugus can happen, and constipation can also be present in those kind of issues. So all this we are gonna understand. If the muscles are tight, it can do voiding dysfunctions. or pain, and that pain will be the first symptom, and pain can be into this functional whenever we are doing voiding, and as well as the pain can be consistent pain inside into the organs. If muscles are tight, that can create a tightness to the prostate of a male, and they might start giving the pain, a deeper pain and pelvic pain kind of symptoms, and that can affect their rectum also, and they might start doing some kind of blotting into the abdomen, the gas-like sensation, because muscles are very tense down there and they fail to release and they fail to help into voiding. So that can give consistent acute or chronic type of pelvic pain. So that pain can be during voiding or during sexual activities, or consistently it can be inside. They might keep feeling it. And we have many, many ligaments which is there to hold the organs in the right place, because organs are there and an organ has its own system. So they have a ligament, and if the muscles are tight, they can create a tightness to refer tightness to the organs and to their supportive structures, like their ligaments can also become tight also. So patient can have sustained continuous pain into the pelvic region, whatever ligaments are involved into that particular region. So now let's understand, this is a brief introduction that this can be condition, and now we are going to help our patient in all these conditions. Again, naming it urine incontinence, and there are different type of urine incontinence. Fecal incontinence, there can be hemorrhoids, piles, there can be patient who is having erectile dysfunction, there can be patient who is having premature ejaculation, there can be a person who is having pain related issues like prostate, might be patient is having prostatitis, there's the inflammation of the prostate, and which can affect the urine flow and pain during urination. And it can be dyspareunia, like pain during insertion inside the rectal region. It can be, you can say, anismus, when your complete muscles are spasmodic. It can be specifically one muscle tightness, like puborectalis muscle tightness. So puborectalis syndrome or puborectalis fugus. So these are the conditions. And after that, there might be some surgeries patient has to go for, like they might go for prostate removal. And after prostate removal, patient will definitely 90% of the population is going to feel incontinence issues. So after prostate removal, how physiotherapist plays a big role in creating a strong, sustainable, by making the pelvic floor strong, we can help the person in managing the continence. And same way, if the hemorrhoids are there, and there are 4 grades of hemorrhoids. So after second, third, and fourth grade, if they have to remove the hemorrhoid, and after that, this kind of surgeries, so whatever the way they are removing the hemorrhoids, after the surgeries, the whole anal structure will start creating some kind of tightening, and we need to release those external anal sphincter fibers at that case also. So this is what we all are gonna learn in our 5 days of learning through this webinars. I always believe that anatomy is an important aspect. If you understand anatomy and physiology and the cause is the factor, then you can educate your people, your patient who's coming in front of you. Best education means best involvement of your patient with you. So education is very, very important. So for this, I am going to spend today's time in understanding this anatomy and physiology of the pelvic floor muscle, specifically in male case. Now, I asked one question to all of you: how many muscles are present into the pelvic floor? And the answer is not there. It's all right. But try to write down the answer. But otherwise, let's now note it down, how many muscles are there, step by step. So this is the first slide. Pelvic floor is the muscular diaphragm which separates pelvic cavity above to the perineal area below. Now, very important that this is the inner aspect where organs are lying and organs are coming in direct connection with the pelvic floor into deeper layer. And now same way, when we are saying this muscle is separating the pelvic cavity with the external surface. Now over here, if you see the male body, so we are having a penile structure, we have pubic symphysis, we have perineal body, we have anal canal. So all these are the outer external genitals. So this muscle is separating these pelvic organs with the external genitals. So very, very important kind of one flooring it is, okay, covering it. I got one answer, 14 muscles. Thank you. Thank you so much for writing. All right. What we are going to learn, we're going to cover in all these days, anatomy, physiology, function of pelvic organs with respective canals, bladder of a male, urethra in a male, prostate, urethral sphincters, anal sphincters, rectum, anal canal, anatomy, physiology, functioning of the pelvic floor muscles, micturition process with the role of nervous system, common pelvic floor dysfunctions like hypotonous pelvic floor dysfunction, urine incontinence, types of urine incontinence, pelvic organ prolapse, fecal incontinence, piles, hemorrhoid, fistula. We'll understand hypertonous pelvic floor dysfunctions like chronic pelvic pain syndrome, interstitial cystitis, chronic pelvic pain, dyspnea, constipation, anismus. And we also try to understand, we will also get to know about mixed pelvic floor conditions when the patient is suffering from both hypo at one place and hyper at one place. So this is all are the condition where you are going to support your patient after these 5 days. And this you are going to add this new area in your practice. Patient guidelines and procedure, how to educate your patient and how to start the procedure of the rehab and assessment. Assessment and examination of abdomen, male genitals, external as well as internal. Externally, we have to do the palpation into perineal body, around the penile structure, anal canal, and the muscles which is present there. And internally, the approach is transrectal approach in male. So by inserting our finger into the anal through the anal canal, we'll palpate the rectum and we'll try to palpate other structures through the anal canal itself. Like a prostate of a male, we can palpate, P-spot of a male, we can palpate, bladder we can palpate, and coccyx we can palpate, and the muscles as well, which is present there. And pelvic floor muscle, after that palpation, we have to use lot of rating scales. There are 2 to 3 rating scales the whole world is using, Oxford MMT grading system. And with that system, there's another system that is a perfect scale, and which is used by all the pelvic rehab therapists across world. And after that also there are 1 or 2 scales which I have created. I will also give you that understanding of those scales. How to do examination of the rectum and what are the neurological examination, because nerves are also involved. Nerves which supply the organs, they can be the culprit sometimes, and the nerves which supply directly, which is responsible for pelvic floor muscle action, they can be they are also important to understand. After this assessment and examination and taking the complete history of a patient and taking the whole assessment, the whole body general assessment as well as the pelvic floor assessment, then we will create a better rehab and treatment plan for our patient. And that rehab protocol depends, we are going to use many different level approach. We might use our manual therapies, whatever therapies we are using in other conditions. We are going to use our hands, our fingers to release the muscles if they're tight, and like trigger point release techniques. It can be myofascial release techniques, or you can use the massage techniques, muscle lengthening techniques, and same way strengthening exercises by giving them the proprioception with our fingers. That is very important. Same way, we are going to use electrotherapy modalities, because some cases can be there where patient is not comfortable with the touch, and we might have to take a help from the electrotherapy modalities like TENS, ultrasound, cryotherapy, those kind of things we need to take a help from. Or if the patient is having a very weaker muscles, just to create this passive action, we might we need a help from electrical muscular stimulations. So stimulators we might need Faradic stimulators, or in some cases galvanic stimulations. We might need stimulations to different nerve pathway. We need IFT support as well, or transrectal probes are also available into the market when the muscles power is not at all there. One power, two power is there. So just to make the muscle functional and active, we have to take a support from this kind of biofeedback devices also. And there is another device like vibrators are also there. So all these kind of devices we are going to understand how to use. And after that, exercise. Exercise plays a big role. You might have heard about Kegel exercise. And the Kegel means contraction. So how to create a contraction. So we will understand the Kegel and how to start Kegel in like starting from the basic position, and how we can upgrade that. So how we can go for this progressive exercise protocol. So we'll understand everything and exercise not only the pelvic floor muscle, even all the accessory region as well. We might understood that patient is having a very weaker pelvic floor, and simultaneously patient is also having a weaker glutes, weaker adductors, weaker abdominals, might be suffering from diastasis recti. So this is all can be found, and we might have to correct that, and we might have to strengthen those accessory area as well, because they are the neighbors. So we need a strong neighbor so they can help the pelvic floor in a better functioning. And in sometimes this neighbors can be more extra. They might be spasmodic neighbors. They might have a tightness, and because of the tightness can refer towards the pelvic floor muscle, and we might need a release of those areas. So taking care of accessory muscles around the pelvic region is also very, very important. So exercising them, either the strengthening exercises or either that releasing exercises are very, very important, which can create the flexibility into the region. So we'll understand that. And very important is a lifestyle and behavioral therapy. Whenever we have to understand the factor which is affecting which is the cause of pelvic floor dysfunction, like obesity is a common cause, constipation is the common cause, some kind of like involvement into some kind of jobs like pulling, pushing, when we are doing a lot of Valsalva, where our breathing pattern is not good, where we have a habit of unnecessarily holding our stool and our urine, we are not passing them on time. So irregularity is there. So it is important to give them that kind of good modifications according to the training program we required for our patients. And not only this lifestyle and behavioral therapy, we are going to work on to the good posture of a person, better ergonomic breathing pattern, bladder diary, bladder retraining. There are some techniques, neck techniques. So dietary support, what type of food they have to go through, we'll understand. And home exercise plan. Very important that patient can come to us for 1 month, 2 month, 3 month maximum. They are not going to come to us every time. So it's important that we, after this better education, better awareness about their own body, we can add something into their own day-to-day plans. But like just keep exercising your pelvic floor as well. And so this is all we are going to understand into these sessions. So I'm so happy again to have all of you. And this is a beautiful image which you can see here on the screen. Pelvis is the area between the abdomen and lower body. And it includes body pelvis with its structure, pelvic cavity with pelvic organs. Then we are having a pelvic floor muscles internally, and perineal area and external genitals externally. So this image, if you see here, right now you can palpate in your own body if you are at a comfortable place where you can touch yourself. So you can palpate yourself like that. You can palpate your ASIS. You can palpate your pubic symphysis here, the bony structure. Now from this particular anterior and then posterior, we are having a sacrum. So this is all pelvic cavity. And in this pelvic cavity, you can see just behind this bone, pubic bone, the first organ which is lying in a male body, that is the bladder. And same organ is lying in a female body also, just behind the pubic symphysis. any one of you whose bladder is full, you can touch yourself just suprapubically over here and try to put a deeper pressure. You might feel some urinal sensation when you are pressing suprapubically. Pressure you apply. So at that time, you might feel that there's a bladder, that sensation also. So bladder is those kind of, it's like a balloon which can deflate and inflate according to how much feeling is going on. It's a reservoir which is connected with the kidneys through the ureters. Two ureters are coming and they are keep filling this bladder with the urine, and this bladder is present. When it is deflated balloon, it will stay into the pelvic cavity, and when it will start getting filled up, it will come into the abdomen. It can extend up to the abdominal cavity also. So when the urine bladder is full and if you press, it might give you urinal sensation. So we can definitely palpate our own pubic symphysis, and we can assume, we can visualize that our bladder is just behind this pubic symphysis. And the bladder is having one canal which is passing through that's the urethra. And now behind this particular bladder, just beneath the bladder, we are having a prostrate gland in male. We will understand that as well. And just posterior to the bladder and prostrate, you can see this is the last part of the colon, the rectum. And then this rectum is the organ again, and it is crossing through, it is touching the pelvic floor muscle. This is a beautiful image where you can see that how beautiful it is touching. Look, it is touching, the organs are touching. These are the pelvic floor muscles. So it is resting on the pelvic floors. So pelvic floor are the supporters. That's why it is a supportive function. Pelvic floor has a supportive function. And now through that pelvic floor, this is also giving a way. So through that, their canals can pass. So anal canal can pass. So when something is passing, so muscles are wrapping around that particular canals, and they can create this opening and closing effect around the canals. And this opening and closing effect, in our medical terminology, we are saying it as a sphincteric role. So they can work as a closing sphincter and releasing also. Sphincteric role is also there. So supportive role, sphincteric role, and you can also understand the pelvic floor is connected from the pubic symphysis to the back. So they also has this kind of all stability. They are providing the stability to this bony part of our body. So they are stabilizer as well. And now this area, we have our sexual organs are also present. If we say about female body, so in female, we have our special organ, that's the clitoris, which is sandwiched between the layers. And same way in male, we have our penile structure, and which is going to serve as a erection, which is going to go for erection during the sexual activity and arousal. So muscle has a very beautiful and good role in creating better blood supply towards that penile structure and sexual organs during the orgasm, during these sexual activities, arousal state. So pelvic floor has a sexual role as well. So these are the 4 roles so far, which I gave you. Now, the another is it's going to work because, as I told you, it is going to, like a calf muscle, it's going to help in creating the pumping back towards the heart, blood pumping back towards the heart. So venous return is going to help into that. And so they have a role into circulation. We have many blood vessels present into this particular region down just beneath around the canals. Specifically around the anal canal, where there are too many arteries which is supplying the external muscles, external anal sphincters, or pelvic floor muscles, or the anal canals or rectal area. So all these arteries, and then we have a veins present here. The veins, as per the gravity, they will be always, gravity will keep pulling them downwards, but the pelvic floor will keep getting contraction, and they will help in pumping the blood back towards the heart. Sometimes, if they fail to create a pumping because of any continuous pressure, patient can develop hemorrhoids and piles. And so that is again a circulatory dysfunction of the pelvic floor. So in this case also, so these are the 5 important role of the pelvic floor, which you can understand through these beautiful images. And if you see that this is on the top, bladder and the rectum. So all completely on the top of the bladder in a male body, we have the all intestines are lying, large intestine, small intestine, they're just lying into top. And what is the difference in male and female? You can understand that between bladder and the rectum, we have, as a female, I have uterus, which is present into the central part. It's a central organ. So on the top of the bladder, uterus will be present. So if I'll assume that this is a female body, so I can create this kind of bladder, uterus here. And uterus is having a cervix, and then it is attached with the vaginal canal. So this is how 3 organs will be there in a female body, and 2 organs are, and this organ is not present in male. So this is this is the difference between male and female. Now you all are very senior to me. You all are aware about the pelvic bone, but still you can take a screenshot of that and just read it. It's just for, I'm not taking this slide in a detailed way. So please take a screenshot, because palpation is important. Landmarks are important. And after that, we should also understand the difference between that male and female pelvic bone. So please take a screenshot of that as well. And now here, I want to bring your attention towards very important part of our, which we should not miss during our assessment. And that part is that pubic arch. So you just please take a screenshot of this as well. So we all know that female are having 3 organs, and because of the presence of 3 organs, and because of the female are going to get pregnant one day, uterus will expand, we need more space, and after that pregnancy, throughout the pregnancy, uterus will keep expanding, and then will keep accommodating the baby inside, and after during the childbirth, baby is going to come out by crossing this pelvic region through the vagina outside. So we need more space into the pelvic cavity. So their bones are more wider bones in female. If you talk about the ilium, so ilium is very wider as compared to male. Male iliac crust and male ilium is more narrower, and female is more wider. Same way, male, the sacrum is elongated sacrum. It's kind of, it's not a broad sacrum, it's a long sacrum. And female is having a broad sacrum. And same way, when we're talking about the anterior aspect, so we have pubic symphysis. Male pubic symphysis is long pubic symphysis. This whole pubic bone is kind of elongated, long, and female is having a broad. And when we are having a broad, and another thing is a connective tissue which is present between this pubic symphysis, this connective tissue or the SI joint back also. And so you can understand that we don't have that mobility in male body. You cannot feel the sacrum mobility. It's very hard to feel the sacrum mobility in male, but we can see we can feel the sacrum and the movable sacrum in females. And it is very, very easy to feel after the childbirth, after a certain age. So sacrum is more mobile because of this connective tissue which is present there. That is even the connective tissue which is present between the pubic symphysis, they are under the effect of some special hormones. So whenever those hormones will come in our life as a female, like relaxing hormone, those relaxing hormones are going to create more relaxation into the bones and into the connective tissue also. So they are going to give us more kind of mobility. They will create a relaxation. So they will create a more spacing between the joints, just to create more space into the pelvic cavity to accommodate the baby. So during the 9th month, 8th month, 9th month of the pregnancy, and during the childbirth, during labor time period, so there will be more laxity happens during the pubic. And this is what we are saying is a pubic recti. They might separate from each other. That tissue can stretch out between them. And if that is happening, it is going to create a lot of instability issues with the female. And those pelvic instability issues are not common in male, because there are no no relaxing is coming. There's no effect of hormones into their pelvic region. So that's why those kind of SI joint dysfunctions or those kind of pubic symphysis dysfunctions or pubic pain dysfunctions are not very, an instability type of issues. They are not very common in male. They are highly common in female. 80 to 85% of female, they are suffering from issues with the pelvic cavity. And after certain age, after menopause, after delivery, you might have observed that gait of the patient is, gait of a female is also changed. It's because of this instability which they acquire into that region after a lot of relaxing effect. But male don't have those kind of issues a lot. Now over here, very important thing which is important for the assessment is assessing the pubic arch. So this is one area you can say, like we have this pubic symphysis, and we can palpate our pubic symphysis, and you can palpate your sit bone also on the sides. And then this is a pubic rami and ischial rami. So this is a pubic rami which is going on, and ischial rami. So by following these two both part, you might find one angle when these both are coming closer together with each other. Both bones are coming with each other. So this kind of angle, we are calling it as a pubic arch. So this pubic arch is narrower in female, in male, 60 to, because with this, the ischial, it means they are narrow. Narrow means their ischial tuberosities are closer together. They are not away from each other. They are closer to each other more, because we don't need any mobility, any movements into that area inside. So the pubic arch is narrow in male, and the same pubic arch is wider in female. It means sits bone or ischial tuberosity of a female is wide, is away from each other. There's more space between them, but in male, less space is there between them. And why it is important for the assessment? Sometimes whenever your patient will come to you, so we have to assess the pubic arch of a patient by putting our fingers like this. So we'll give them a position, supine position, crook-line position actually, and then without removing the cloth of a person, it should be the loose cloth so we can touch the bony surface. So we can palpate the ischial tuberosity, and we can bring our finger by just palpating the bone on the side like this. So one finger on one side, and then you can palpate other side, and you can bring your other finger also like this. Or you can bring your both thumb. You can use your thumb also as a therapist like this. So you can bring your both thumb and you can just see. And now this is what you have to note. How much angle is there? Is it 60 to 70? Okay. And if it is less than 60, if it is 40 and 50, you can understand there's more narrowing is going on. That might create a congestion inside and pelvic pain. It can be why it is narrow, because of the muscles which is present. They might be tight and they are bringing them together. So because of this tension into the muscle and some kind of shortening into the muscle, this arch can become narrow. And in this case, hypertonus cases, you will found narrow arch. So in this case, we have to release the muscles to make the arch better again. And if the arch is more than 80, so which will be very common in your patient who are obese patient, because of continuous weight, their muscles might be lax muscle, weaker muscle. And because of the weaker muscle, so it's like a fibers of the muscle, these muscle fibers. So these muscle fibers can become lengthy. If they will become elongated, they will not bring the ischial tuberosity together. So they will create a laxity between here, and they might create more space between ischial tuberosity. That can show you more broader angle. If angle is broad, so that is so without even touching the person internally, without removing their clothes, just by palpating their angles, we can find out our patient and the symptoms of a patient also, that they might be suffering from weaker muscles, lax muscles, or they might be having the tighter or hypertonus muscles. So pubic arch is very, very important. So this is where we can take from this slide. And now rest, you please take a screenshot. Yes. Male don't have that much of mobility into the pelvic region. Same whole bone is now we understand whenever we are in a standing position, we have a certain positioning of our bone, the pelvis bone which is lying there. And this, who is maintaining this? Like you can see that we are having this ASIS, some kind of anterior tilt is there always. So now this is who is responsible for this kind of positioning of the pelvic bone in our body. The major responsibility of providing this good support, good stability and good position to this bone into the body is depending upon the ligaments, which is supporting that. So there are 4 ligaments which is holding the bone in a right direction, and we have to always palpate these ligaments, those structures, whenever we are doing the pelvic assessment of our patient. So you can see here there are 4 different colors we are using, and one is the red color which is holding both pubic bone together. So this is the pubic ligament. Then we have another green color, which is like this is a pubic tubercle of one side, and then we have ASIS. So this ligament is completely attaching, is between this ASIS and pubic symphysis. And if the ligament is good into position and shape and texture, it will maintain it will keep pulling this whole bone bit anteriorly. It will keep moving it anteriorly. Okay. And if the ligament will be over tight, it will give like you can say more anterior pelvic tilt. It will add into anterior pelvic tilt. If this ligament will start getting shorter or because of any surgery around this region suprapubically, any small surgery also, it can be any surgery happens to the abdomen area, around the prostate, hernias, anything can create adhesions into the tissues and adhesions into the ligament also. And because of this adhesion and scarring, these ligaments can start getting tighter, and the muscles which is also coming here, and they can pull the bone anteriorly and can start showing the patient anterior pelvic tilting. So patient can show you more anterior pelvic tilt, and the posture will somewhere change. And if the patient will come in more anterior pelvic tilt, you can see that their sacrum will also get affected, their coccyx will also get affected in this case. They might also they will be prone to develop coccydynia because of the anterior pelvic tilt. Patient will show you that can start showing them congestion kind of syndrome anteriorly, and they might also put pressure over the structure like bladder, which is present just behind this pubic symphysis. If we have a tightness anteriorly, that might put a pressure over bladder, and it might also affect the this expansion of bladder during the filling phase. That can simultaneously will increase the urinary frequency of the patient, because bladder cannot feel more urine into the bladder. So this patient has to go again and again for voiding. The frequency of urination can be also high. So just a simple one ligament tightness, you can understand how it can affect the complete posture, even the coccydynia, or even the urinary frequency. So, and it can also start showing this pubic symphysis pain to the patient. This site will be painful. It will palpate. And this is a site where our abdominal muscles are also somewhere coming and they are merging. And connective tissue, linea alba is also coming and it's merging. So you can understand it can create a tightness into the abdominals also. So this ligament is important to understand, and we have to always palpate ASIS and pubic symphysis, and the whole structure and the ligament is there. We have to visualize that and try to put a pressure and try to find out if there's any kind of symptom patient is showing you, tightness symptoms patient is showing you. So we can keep in mind. Same way, if you just see another ligament which is present between the sacrum and ilium, so that's the posterior sacroiliac ligament, which is in this color, blue color is showing into this image. So this is again important ligament which is holding these two bones together. Again, this SI joint pain is not that much common in males, but because always ligament are but yeah, some kind of surgery happens, definitely it can affect these ligaments. Or if the patient is always, nowadays what we are having, we are always into this kind of bad sitting positions. So whenever we have this kind of sacral sitting position, that can put extra loading on the sacrum, and it can create some kind of laxity changes into the ligament, not the hormones. The pressure can create some kind of change. So, but not very common in male, but still. And so this is one ligament which is important for the stability. And now posteriorly, the yellow color, we are having one ligament. We have a sacrum, S3, S4, and the coccyx also at the down over here. This is all picture I'm talking about. Now from here, we again, we have an ischial spine inside. So one ligament is coming from sacrum to ischial spine, and we are calling it as a sacrospinous ligament. This ligament is again important for providing the best stability to the pelvic bone. All these ligaments are important bone stability, and this ligaments is very important, sacrospinous ligament, during, you can understand, if this ligament can become tight, which is common because of the sacral sitting, a lot of pressure might affect this ligament. So it can create laxity, or it can always start showing you some kind of laxity with the coccyx. So it can be responsible for the sacral pain and the coccydynia as well. If the ligament is weak, lax, it can give coccydynia. And if the ligament is tight, it can create some kind of tightness into the anococcygeal body and other structures, which we will understand in upcoming slides. And if this ligament is tight, sacrospinous ligament, it can show patient posterior pelvic tilt. Okay, the tilting will be posteriorly to the patient. Same way, if one side of the ligament is tight and one is, it can show the lateral tilts, side tilts to the patient also. Okay, so this tilt of the pelvic region, so we should always keep in our mind the ligaments can be there, as well as that muscles, other structures can also show those kind of tilting. So muscle tightness or ligament tightness, which can be cause of it. So these are the four ligament which is providing the stability. And after that, once we are understanding, let's go and understand male body more better. So this whole bone is somewhere supported by the ligament, and the downward we have pelvic floor, and inside we have pelvic organ, outside we have pelvic external genitals. Okay, now let's go one by one and understand what is all together here. In this image, this is the pubic symphysis, which we just talk about. This is the sacrum and coccyx we talk about. And then this is the bladder, and this is the rectum. And bladder is just, this is the bladder, and from the bladder we have this urethra which is coming out. As soon as the urethra is coming out, urethra for male is very long. So female urethra is only 4 centimeters long, but male, which is something like that, and it will open into the perineal body, and we are having this all vulva here. But male urethra is very long urethra. It's approximately 17 to 18 centimeters long, 4 times more bigger than female urethra. And this urethra is piercing, this is a passage. I will not say it is the urethra only, it is a passage actually. So this whole passage is quite long passage, which is all crossing through different organs. Now, when this passage is crossing, the first crossing is, it is starting from the bladder, then it will cross first through the, now it is encircled by important organ of a male, prostate, where this all the semen fluids, everything is staying. Okay, so this is the prostate, and we have the seminal vesicles where the semens are produced, and we have these ducts are also present. So from this ducts, the semen will come by, it will store into the prostate, and after that it will come outside during ejaculation. And so this whole passage is behaving in a serving, the passage which I'm talking about, this passage is serving for two functioning. It is it has it has a urination functioning, or it also has a ejaculation functioning. So this urethra is passing through the prostate, and then urethra is passing through another structure, this one, this structure. So this is pelvic floor muscles. So this is the second. You can see there are three floors actually through which this urethra has to keep coming downwards. So this is the one, prostrate, and then the pelvic floor muscle second, and then the penile structure third. Okay, so these, after passing through these three structures, you can say the urethral meatus or urethral orifice, external urethral orifice, we can see externally onto the penile structure. So, and this whole urethra is, you can see that we have many other structures which is encircling it. So we'll understand the whole penile structure as well. What is present, the corpus cavernosum, arteries, veins, everything is there into this particular area. And now the body of the penis and even the base body as well as the, external part. We'll understand. And then just beneath, so this is a one urethra which is crossing through these three things, and posterior to the, okay, posterior to this, you can say we are having a rectum, and rectum is passing through the pelvic floor. And it is supported by pelvic floor. So one muscle is coming from here, like my cursor is going on. So one muscle is coming from pubic symphysis, this one, and it will hold the rectum anteriorly like this. So the name of this muscle is puborectalis muscle. We will understand that. And then this rectum is finishing, and with the anal canal will start. Anal canal is very shorter canal. It's around 3.5 centimeter long, 3 to 3.5 centimeter long only. And this whole canal is passing through the pelvic floor muscle. So over here, you can see these are the pelvic floor muscles on the sides. So complete 3.5 length is covered by external anal sphincter, which is the strongest pelvic floor muscle. Okay. And now in this way, you can understand the anal canal externally also here. So every canal, it can be the urethral canal or anal canal, they have two openings. One opening is towards the bladder and one opening is external opening outside. So we call it as an internal opening or internal meatus, or external opening or external meatus or external urethral opening. Okay, anything you can say that. Same way, when we are talking about the rectal anal structure, so we have an internal opening of the anal canal and external orifice of the anal canal, internal orifice and external orifice. Assume there's a tunnel, okay, something like a tunnel. These tunnels have two openings, outer and inner. Okay, urethra as well as the rectum. And these tunnels are passing through different structures. If it's a urethra, it will pass through the prostrate, it will pass through the pelvic floor muscle, and it will pass through the penile structure. And if it is it is an anal canal, so it will pass through the external anal sphincters. Okay, so this is how these structures are present inside. There is space between bladder and that what we are saying is the rectum, this particular area where the male sexual reproductive organs are present. Okay, the seminal vesicles are present in this particular area. And now, when we are talking about the male and we want to palpate the male structures like pelvic floor muscle, if you want to palpate in a male, so we have only one approach. We have two approaches actually, external approach and internal approach. So externally, you can palpate outside just beneath the scrotum, the muscles you can palpate, and internally, it's only one approach, transrectally. We can insert our finger transrectally and we can see the status of, we can try to insert our finger transrectally and we can see the structure of property of the external anal sphincter, how relaxed they are. If they are relaxed, it will be easy for you to penetrate your finger inside. You can go and you can feel the complete rectum of a male, like depending upon the length of your finger actually. So how long is your length? You can feel the rectum, and then if you move your finger posteriorly towards the coccyx, you can feel the coccyx of a male, and you can feel this coccygeal ligament also. You can feel the sacrum as well, because coccyx, depending upon how long is your finger, okay? The lower part of the sacrum you can also palpate, and that anococcygeal ligament, which I told you, this sacrospinous ligament also you can palpate. And then If you move your finger anteriorly towards the pubic symphysis, so just very down, as soon as you enter, you can feel the prostate. And like prostate is like a sexual, it's going to, whenever you touch the prostate, it's going to give the sexual sensation to the male because it is a sexual organ. So we, like a females, they have a G spot in their vagina. The male, they have a P spot in their rectum, and there's palpation. So this touch. So as soon as we'll touch it, you can, patient can feel sexual sensation. But if the patient is having an inflamed prostate, prostatitis is going on, if you will touch, it can give them pain also, or painful sensation as well. Or we can see this kind of inflamed prostate through the transrectal approach by touching the anterior wall of the anal canal. Anterior wall of the rectal canal. Okay, and if you move your finger more deeper upside, and you'll keep palpating this, keep feeling this anterior wall of the rectum, you can even feel the posterior wall of bladder with your finger. And if you move you can feel this bladder if it is filled, and it is completely filled bladder. It is full bladder actually. And if you press with your finger and you'll ask your patient, are you feeling urinal sensation? He will tell you that yes, it is urinal sensation. So means you are at the exact area, you're touching the bladder. If you are asking a patient, are you feeling sexual sensation? It means you are touching the prostate of a male. So the bladder and prostate is somewhere anteriorly towards pubic symphysis, and coccyx is posteriorly towards the posterior surface of the anal canal. Towards the rectal canal. Now, anterior posterior, we understand the organs are there, but what is present on the sides, lateral sides? Laterally, we have pelvic floor muscles. Now, in this image, again, if you are inserting your finger through the rectum here, so you can feel the anterior organs, posterior organs. But if you're moving your finger on the sides, all the muscles will be felt on the sides with your finger, okay? Like this. So you can just move your finger from as far as you can go upside. You can just move like swipe like this, like scoop like this, and you can feel all this pelvic floor muscles on the side through transrectal approach in male. Okay, it's very narrow. My finger can't go, but assume that you will be able to feel because your finger length will be bigger. So laterally, pelvic floor muscles are there. So whenever you have to assess the pelvic floor muscle, your finger will go laterally and posterior also, because muscles are attached with the sacrum and coccyx. So posterior and lateral, you cannot go anterior, because anteriorly organs will be there. So always assume there's a clock inside. So assume we have a clock inside, this clock. Okay, the same clock you can assume here. So 12 o'clock, 1 o'clock, 2 o'clock, same clock you can assume. So 12 will be always upside, anteriorly. So that will be always towards pubic symphysis. If I'll tell you 12 o'clock, so who is present 12 o'clock? Which structures are present 12 o'clock into the transrectal approach? So bladder is present 12 o'clock. This prostate is present 12 o'clock. Okay, they are present up towards pubic symphysis. So 12. And if I'll say you, okay, 6. So 12 up, 6 is down. So 6 means what is present at 6 o'clock? Coccyx is present 6 o'clock. So this is how 12 and 6 is coccyx and the anterior organs. But on the sides, all the sides, pelvic floor muscles are present on the sides. So through the rectal canal, assume like you're inserting your finger into condom. So you can stretch the condom on one side. Same way you are going to stretch the rectal canal on one side. So through the rectal canal, you are going to touch the muscles. We cannot touch the muscle directly. We are inside the rectum. So we are going to stretch the rectum and we are going to touch the muscles on the sides. So all these sides, like 11 o'clock, 11, 10, 9, 8, 7, 6, because this is also muscles now behind. So 6 o'clock, and then again this side 5, 4, 3, 2. All these sides are the muscles everywhere. So now let's understand every structure one by one. I'm sorry if this picture is a bit offensive for some of you, but it is very important to understand when your patient is going to come. And it's always, this is the male genitals. So beautiful picture. You can see this is a pubic symphysis, and behind is the bladder. And urethra, how it is passing, and how urethra is having two openings. One opening is coming from the bladder, and one opening is coming from the seminal vesicles. And this is all the passage which is crossing through the penile structure. And then we have this seminal, these testes are present, two testes are present, which is present inside the scrotum. So if you just lift the penile structure, beneath that, we will find the scrotum. Inside the scrotum, we have the testes, which is present here. Okay. And so this is again urinary bladder location. This is the location posteriorly. And pubic bone. So we have to palpate pubic bone in case of whenever a patient is showing you painful, chronic pain is the symptoms are telling the pain is there around the area. And then this is scrotum, penile shaft. So these are the structures actually. Posteriorly, we have this anal canal. And you can see there's more space between this whole base of the penile structure as well as the anal canal. So their perineal body is more longer perineal body. The space between that is more wider. So that's why laxity issues are not that much into male. Prolapse kind of things are not that common in male. Penis. Let's understand the first organ, penile structure. Penile structure is very, very important organ, which is an organ for urinal system as well, which is responsible for urinal system, urination, and for the reproduction also, because that semens are coming through that, sperms, ejaculation is coming through that. So this is the important area. The penile is a cylindrical into shape and consists, there are three parts of the penile structure. One is the body, like this is the body. If you understood the clitoris, there are three parts in the clitoris also. The legs are there, then the body is there, and the glans is there. Same way, the penile is also having the body, which is just attached with this very near to the muscles, pelvic floor muscles, wrapped by the pelvic floor muscles also. And then we have, so this is, root, which is wrapped by the pelvic floor muscle. And then we have a long body of it. And some of the body is inside and some of the body is outside. And then externally, we are having this kind of glands. So now in this structure, you can say that we have different type of skin and shape is present into body. That skin and shape is not present into the glands. It means this body is always, whenever we are saying erection or erected penis, erection always happens into the body of the penile structure. It never happens into this glands. It is always into the body because of the presence of those different structure. And through that penile structure, the urethra or the passage is coming out. We should not say only urethra, this passage, it's a passage. And through this passage, urinary as well as the sexually functioning will be achieved. Now, the function of penile is a urination, erection, and ejaculation. Urination is the process we know that is coming through the bladder. We are going to empty the bladder and pass the urination. And then if you want to hold, you can even keep holding it. And it's a passage. It's a passage. The whole penile structure is going to go for erection. It will become rigid whenever patient will have this desire of sexual, when they will into the sexual functioning, desire will be there. So that erection will happen into this. And after this erection, when they will hit orgasm. After hitting the orgasm, there will be release of the fluid, ejaculation, that the reproductive fluid will come outside. Semen will come externally. So these are the three important functions of the penile structure. And during sexual intercourse, during erotic stimulation, the penis undergoes erection, becoming engorged with blood following emission, mixture of the component of semen in the prostate urethra. Ejaculation will happen, and then semen will move out through this external urethra. And then if it can serve its purpose of reproduction also, if it is required. Now the structures, when we are talking about, there are three structures: root, body, and the glands. So over here, beautiful image, which we can explain you. This yellow part is a root, which is attached directly with the muscles, pelvic floor muscles. And then we have a body, and then we have a glands in a blue color. root is most proximal fixed part of the penis, which is not movable and is not visible externally. The root contains three erectile tissue. Not only the root, I think the whole penile structure is containing up to the body and some part of the glands also. So whole this structure is containing these erectile tissue, three erectile tissue, two cruras and the bulb and one bulb of the penile structure. So you can see this is if you just separate it with each other. So this is the bulb of the penile structure. And then we are having, this is a crura on the side. So crura is something wrapping, like assume that I'm holding this pen in my hand. So my hand is crura, okay, coming from the either sides. And so this is how this structure is present. So these are two cruras on either side, and this is the, we also call it as a corpus cavernosa. Corpus cavernosa. And this is a corpus spongiosum. This is a corpus spongiosum. And through the corpus spongiosum, the urethra is passing. Okay. The most proximal fixed part, and which is having this area, and the root of the penile structure, this is the area where our pelvic floor muscles are attached. So whenever we are saying erection, or we need to pump up blood towards the body, because body is going to show the erection. So we need more filling of the blood towards that body. So at that time, this pelvic floor muscles are going to work as a pumping muscles, circulatory muscles. It will help in pumping more blood towards the body, and it will help into a better rigid erection. And so the two muscles which is present here, pelvic floor, is the ischiocavernosus and bulbospongiosus. Very, very important muscle. We'll understand that in upcoming slides. After that, we have a body, the free part of the penile located between the root and glans. So this is the glans externally and the root. It is suspended from the pubic symphysis. It is composed of, again, the same, as I told you, that this corpus cavernosus and corpus spongiosum, they will keep going downwards, okay, like that. So they are again enclosed between that whole area. The body is also enclosed between this two corpora cavernosas and one spongiosum. And after that, we have this glans. Glans is most distal part of the penile structure, which is conical in shape and is formed by the distal expansion of the corpus spongiosum. You can see in this image, it is distally, it is coming out. This contains the opening of, and in this particular glans, we have an opening of the urethral orifice. You can see that. I'll show you in upcoming slide. No problem. Okay. Now this is a penile structure. If you see the penile structure from the top, the penile structure is there, is supported by some important ligament, which is holding the penis into the right position. It's not a hanging, like, no, it cannot, it's not a free. Something is holding it, either from the body or either from the root. So these are the ligaments. These are the ligaments. I need to make someone admin. Dr. Vivek is there. Hi, Dr. Vivek. I'm making you co-host. Can you please admitting the people? Yeah, lovely. Dr. Vivek is also there. All right. Sorry, there were 3 people into the waiting room. If you see someone is into the waiting room, please let me know so they should not miss the session. Okay, so now the whole penile structure is supported by the ligaments. And sometimes these ligaments can be the source, can give the source to the pain. If sometimes patient is having pain at the base of the penis, so it can happen because of the any issue which affect these ligaments. So now the root of the penile structure. Oh, Dr. Meena is also there. I'm sorry. Yeah. Let me make you co-host, Dr. Leena. Dr. Meena, thank you so much, dear.
My pleasure.
Please accept. Okay. Now ligaments. The root of the penis is supported by two important ligaments which attach it to the surrounding structure. I like this image actually. So what you can see, we all understand the rectus abdominal muscles, either sides, right and left rectus abdominis, and they are connected with the linea alba which is a connective tissue. Okay, so this umbilicus throughout the up to down, which is coming from the sternum, and the ribs is coming downwards. So now this is a linea alba, and from the linea alba, one ligament is coming, originating from that, and this ligament will encircle the body of the penile structure of the penis. It will hold it upside, and this ligament, we are calling it as a fundiform ligament, a condensation of abdominal subcutaneous tissue. It runs down from the linea alba, surrounding the penile like a sling and attaching to the pubic symphysis. Now, you try to understand what will happen with the patient who is having a very, very tight abs. Tight abs. If the linea alba is also like, it's kind of something happened to this particular region of the linea alba, it can give pain to the body of the penis, or it might affect the erection also. If the ligament is tight, it will not let the corpus cavernosum to expand because of this loop. Loop will pull it upside. So very, very tight core, I will say their tight core is not good for your penile structure. People are like, it's like a fashion. They want to build up 6 abs, but that too much, that can create a issue with the penile structure also. Okay, so it will not let it function efficiently and effectively. So if the fundiform ligament will become tight. So this is one ligament which is holding the penile upside, and we have another ligament which is a suspensory ligament, and this ligament is coming from the pubic symphysis. Now, as I told you that palpate your pubic symphysis, so you are able to palpate this part. Now, from that particular area, this suspensory ligament is going, which is holding the particular region, penile structure upside. And now if we'll see this, this image here, so this is the pubic symphysis, and from there, this is the suspensory ligament, which is holding the root of the penile structure. So you can appreciate this image. This is coming. This is wrong actually. This image is wrong. This is not a suspensory ligament. Suspensory ligament is this one. And this is a fundiform ligament. Okay. I hope you're clear. And the fundiform ligament is like a sling of that. So these are the ligaments and the body. And then we have another important structure is a facial covering, which is covering the whole penile structure. If you'll understand that one by one, so there was a corpus spongiosum, and then there was a corpus cavernosum on the both sides. This is the corpus cavernosum on the both sides and spongiosum. And this is again a picture, if you just cross section it. So yeah, this is a corpus spongiosum. And we have into corpus spongiosum, one, and we have both side corpus cavernosum. Okay? And then we have a facial sheath. And these are the veins. This is the vein. We have arteries. Arteries are going. So arterial supply, penile arteries. So the blood is coming into this particular region whenever male is aroused sexually. So blood flow will come, and because of the blood flow, all this spongiosum will start getting filled up with the blood, and we can see the erectile tissues. It is going to give erection to the whole penile structure. And once we are not like when there's no sexual activities are going on, so there's no blood flow into the penile structure. So these cavernosas will be flaccid cavernosas. They are not filled up with the blood, and we can see this kind of flaccid penis. So this is because of the arterial supply which is coming into the corpus spongiosum also, and that blood supply is very, very high towards that, this also, corpus cavernosum also. And you can also see this is all sheath. Tunica albuginea is covering the both structure, the complete both, all these three actually, all these three is covered by the tunica albuginea. And then we have another structure present here, this one, facial sheath. So this is the one deeper facial sheath inside, and then we have this outer superficial facial sheath, and beneath this facial sheath we have veins. So you can say this is a like all penile vein, and this is also penile veins. This is the nerves, which is also gonna, like, no, all the sensations are going to travel from the penile to the brain, from brain to the penile structure. So the sensation, nerves are endings are also there. So you can understand we have nerve endings, we have arteries, we have veins, we have, and that is covered between the superficial and deeper fascia. And we have areolar tissue present in between. And yeah, you can see here. Each mass of erectile tissue has two facial covering, the most superficial layer immediately under the skin. Now you feel the skin, and under the skin, why we have to understand this penile structure, why it is important. Look, we are not a people who are gonna do the rehab of penile, but penile, the base of the penile structure, we have a pelvic floor muscle attached. So it's always important that we have this kind of at least bit understanding about the penis. So that's why I'm covering this. Each mass of erectile tissue has two facial covering. Most superficial layer immediately under the skin is external fascia of Colles, okay, which is continuity with the fascia of Scarpa, which covers the abdominal wall. And a deeper stratum is deep fascia of the penile, known as Buck's fascia. This is a continuation of the deep perineal fascia and forms a strong membranous covering which hold all three erectile organs together. So deeper fascia is also there. Underneath the deep fascia is a strong fascia called tunica albuginea, forming an individual capsule around each cavernosal body, and it is going to fuse into midline. The complete septum between the two corpus cavernosa is comprised with the tunica albuginea. Yeah, there's another muscle. Now, beneath this penile structure, we have a scrotum, and we all are aware about the activity which is going around the scrotum, because inside the scrotum, we have our reproductive organs present. Like in a female body, we have ovaries, male, they have a testes. So they have two testes, and these two testes are wrapped inside the scrotum. And because they are they are keep producing the semen, sperm throughout the life of a male. Female, they have two ovaries, and into these two ovaries, we born up with the eggs. And like we born up with some kind of fixed account. We have account, and into that account, we have a fixed amount deposited already. And one day, like assume that in our account, we have some certain amount of money. One day, this money will spend all the money. Once we'll spend all the money, we cannot we cannot create more money. We cannot earn money. So the body of a female, the ovaries of a female, we born up with the eggs, number of eggs, and one day the egg will the egg is going to the production of the development of the egg is going to start, and one day all the eggs will finish. And this is all the process which is happening during the reproductive time period. When the eggs are starting developing, we are saying that the menarche started, menstruation started. And once when all the eggs will be finished, so we are saying that there's no more eggs left into the ovaries. This is what we are calling it as a menopause. So our body, our reproductive time period, life is depending between this menstruation time period, or starting with the menarche, and it ends with the menopause, and we finished with the eggs. But the male body is not like that. Their organs will keep producing. We don't produce as a female, but they produce. So if they have to produce, they need some kind of strong environment to protect and to support that production also. So they have these testes, and testes are safely enclosed into that scrotum, which is present externally, just beneath the penile structure. Now this whole scrotum, the skin, if you see the skin, beneath the skin, we are having a cremaster muscle. If you are aware about uterus, in uterus, we have myometrium, which is the strongest muscle of the body, of a female body, as strongest smooth muscle of a female body. So like we have a myometrium, we have, if we have a bladder is having a detrusor muscle, same way scrotum is having a cremaster muscle, which is a smooth muscle. And this muscle is under the control of brain. We cannot control this muscle. And this is going to create a contractions, relaxations, depending upon whatever the brain is perceiving. So depending upon, so under this completely CNS effect, it is going to show some kind of reflexes also. So cremaster is a paired muscle because we have two, this testes. The male is having two testes, and so each testis is covered with the cremaster muscles. It is a smooth muscle. This is a paired structure made of thin layer of striated and smooth muscle that covers it, the testes and the spermatic cord in the male. Cremaster is an involuntary muscle. We cannot do anything with it. Works alongside the dartus muscles function it to raise and lower the testes in order to regulate scrotal temperature for optimal spermatogenesis process. Responsible for the cremasteric reflex also, it is a protective layer. It has this kind of physiological superficial reflexes which will keep coming in and out. So depending upon what situation is going on with the male, assume that male is sexually stimulated, sexual arousal is going on. So whenever we need a penile structure to come for erection, at that time penis is gonna somewhere some stimulus is going to happen with the penis. Something is going to connect with closer to the penis. Some external stimuli, it can be anything, it can be. So whenever this penile structure is erected, the scrotum will become the protective scrotum, and it will become shorter into size. It will become more wrinkled, smaller, and body will the scrotum will be it will be retracted closer to the body. And you can see erected penis, more visibility of the erected penis, but not very visible scrotum. It will go for shrinking and shortening, because they have to protect the testes. Nothing should happen. No pressure should go towards the testes. So testes will move closer to the body, not away from the body, very closer. And it's like it will try to hide up somewhere. And it will retract closer to the body. And in cold situations also, whenever we have this kind of cold temperature, whenever patient we are touching, we are doing the cryotherapy with over the penile body of a male, so you will observe that their scrotum will become shorter at that time. It's a automatic reflex going on by the CNS due to this cremaster response. And whenever patient is, same thing is going to happen whenever male is into the fearful situation. Whenever any kind of fear will come into their life, or some kind of stress coming into their life, this is going to create that kind of squeezing around that testes. So it means if a male will be into more stressful situations, and it can affect this kind of spermatogenesis process because of this kind of squeezing of the cremaster muscle. It will not let the testes to function efficiently. So it's important that stress, fearful situations, or the sudden kind of action, accidental touch, or it might affect the sperm formation or productions. The cremaster muscle is an involuntary muscle, and contraction can occur during sexual arousal, which can prevent injury to the testes during sexual intercourse. Contraction also occurs during orgasm and ejaculation. The muscles may contract during movement of extreme fear, cold environment, and possibly to help avoid any injury to the testes. So this kind of movement is going on. So whenever patient is the person is dealing with the fight and flight situation, okay, those kind of response is those kind of hormones are there into the brain, stressful hormones or fearful hormones. So it's going to always create the contraction of cremaster muscles, and it will protect the testes. But too much of production, you can understand it will affect the production of the sperm. Now, let's understand the nerve supply and vascular supply and arterial supply to the penile structure. Very, very important for the erection point of view as well. Sometimes patient has erectile dysfunction. When they have erectile dysfunction, what can be the reason of the erectile dysfunction? The major reason of the erectile dysfunction is if the artery, the blood flow is less. Because of any issue, the blood is not coming to the area. Or not only the blood flow, the first reason can be even the other reason can be the nerves. Nerves, the sensations are not sending signal to the brain. Sensations are not there. No sensation. The nerves are damaged into that area. That can also affect. Or venous, if their veins are also not strongly supporting. So that can be that reason of erectile dysfunction. We'll go more deeper when we'll understand the erectile dysfunction, the specific condition. But in this slide, neurovascular supply, when we are talking about that arteries is coming, this division of, these are the division of internal iliac artery. Internal pudendal artery is the main artery which is going and supplying that whole penile structure, starting from the pelvic floor muscles, which is present here. They're also supplied by the pudendal artery. And then we have the penile structure also, which is complete penile structure, starting from the root, body, and the glands. It's supplied by the branches of the internal pudendal artery. And when they are, after that, they are going to bifurcate which particular area they are supplying. If they are supplying the bulb, so they will become bulbourethral branches. If they are going to go towards the body, corpus cavernosa, spongiosum, they will become more deeper arteries, and then they will go towards more dorsal aspect, dorsal arteries, proximal aspect, proximal arteries. This is how they are going to bifurcate, and more branches they are going to always show. So they are the common penile artery, which is a part of internal pudendal artery, and they will supply the whole penile structure. And every penile structure we are having into the penile structure, like as I told you, we have a corpus spongiosum and cavernosas. They have small, many openings. So, and through these openings, the blood will keep coming into the area, and it's like a balloon, and balloon will like all start getting filled up with this kind of blood, and erection will happen. So there are three arteries: dorsal arteries of the penile, deep arteries of the penile, or bulbourethral arteries. Okay. Now, more deeper understanding of this veins, which is present, and the arteries. Venous blood is drained from the penis by paired vein. The cavernosa space are drained by the deep dorsal vein of the penile structure. And you can say this is a cross-section view. Please take a screenshot. You will find many if you Google it also. So these are the deeper dorsal veins. This is important vein, these veins. Now blood is coming. It is creating this kind of filling into the empty chambers. And after creating when they will start getting filled up, they will move the facial sheath on the sides. Now this is the deeper fascia, and this is the superficial fascia. So the veins are lying between deeper and superficial facial sheath. So when the corpus cavernosas will be filled up, they will extend. They are gonna push that deep. They are gonna put a compression over the deeper fascia and the superficial fascia. They are gonna press it, isn't it? And because of this pressing, because of this filling, the pressing, the veins will get compressed. And when the veins will get compressed, the blood which all came into the penile structure will fail to drain out. So means the blood will stay there till the time the blood, this action is going on, the complete filling is going on of the blood, the erected penis will be inside, and they are going to create a pressure over that compression over the veins as well. So that is the one part why erection will be sustained and maintained. But there's another part is a nitrous oxide release. This is the one important chemical which is secreted during that arousal stage, And this nitrous oxide is gonna create more relaxation of the corpus cavernosas. So if I have a one, let me see. Yeah, this one. I'm so sorry. Yeah, this one. So this corpus cavernosas, which is this kind of small chamber. So these are the arteries, okay? So these small arteries are coming here into cavernosas, and they will bring more blood. They will start getting filled up, and start getting expanding, and they will put the pressure over all this. All this tunica and albuginea will be pressed, superficial fascia, deeper fascia, everything will be pressed or compressed. So now who is responsible for this feeling? Nitrous oxide. What nitrous oxide is going to do, that release, they are going to relax the corpus cavernosas. The more this kind of erectile tissue, this chambers will relax, more blood will come. If nitrous oxide release will not be there, they will fail to relax. If they will not relax, they will fail to fill up blood, maximum blood also inside the penile structure. And so means erection will not be maintained, or it will not happen actually, not maintained, it will not happen because the chambers are not relaxed chambers. So we need a relaxation of the chambers, and that is done because of the nitrous oxide release. And it's very important. But sometimes if that chemical is not being released, because of some heart issues is going on with the patient, the arteries are not functioning well, the supply is not there. It might be the blood supply is not there because of the heart issues, or it can be the nitrous oxide release is also altered. So in this case, you can understand the penis will be always flaccid penis. We cannot bring the blood, and even we cannot, and if blood is still coming, but still the relaxation of this is not going on because of the lack of nitrous oxide release. And that can affect, this is the main cause of erectile dysfunction, arterial blood supply. Okay, the heart is main responsible organ for this, or pumping of the blood towards that. Or if arteries are not in a good conditions, we understand that because of many reasons, there might be the passage, the blood flow can always be altered. There might be some kind of plaque formations going on inside, or something is affecting the arteries. So the narrowing of the arteries can also happen, or atrophied arteries can also happen as per the aging. So we can see that these can affect the blood flow towards this sexual organ. And the second is nitrous oxide release, which is again coming, again, it's depending upon many factors. It's a chemical, which is very important. The release of that is important. But as per some medications we are taking in our life, some health conditions we are having, the male are having in their life, it can always affect the nitrous oxide release as well. So that is the second factor. First, the blood supply. Second is the nitrous oxide. Third is the veins. Veins, we know that every vein of our body, we have this kind of valves present, isn't it? And these valves are always functional. So when we say that the nitrous oxide is creating a relaxation of corpus cavernosas, blood is getting filled up into this all spaces, the chambers. This whole erection will happen. Erectile penile structure is going to put pressure over the veins. Veins will be compressed. So now the vein will be also compressed, and the walls which is present will be also go for closing of the wall, narrowing they will close, and they will help in venous, they will prevent the venous draining. So veins are also very, very important. If the veins health is also not good in a patient, so we can, if the walls are lax walls and they fail to close, and if the corpus, this erection failed to happen because of nitrous oxide, deficiency of the nitrous oxide, so that compression is also not building up. So you can understand the veins will be open veins, and blood will keep coming inside the penile structure, but it will keep draining out also. So now we have two pipes. Through one pipe, blood is coming, but the other pipe should be closed. Otherwise, the blood will drain outside. So that should be compressed, either with the help of the pressure which is generated at that time because of this expansion, or the second thing is the valve's health, the veins health itself. That is also supportive and good. And the third thing which is responsible here is the pelvic floor muscles. Now, in this image, you can see these are the muscles which is covering the bulbocavernosus muscle and ischiocavernosus muscles. Very strongly, these pelvic floor muscles are wrapped around the base and the root of the pelvic floor. So stronger pelvic floor muscle will create a stronger contractions. So once this erection, now blood is coming out, blood should not drain. So at that time, pelvic floor will create this kind of sphincteric action and contractions around the base, and it will help in compressing the dorsal veins. By compressing the dorsal veins, they can sustain that erection inside, and they can even maintain the erection for longer time also. So this is not only one thing which is responsible for erection. There are multiple things: blood supply, then nitrous oxide release, then the pelvic floor muscles, and then the veins. These are the four things all together which is providing erection. And due to this, if the whole health is good, then it they can the erectile dysfunction will not happen. And if any of the factor out of these four things are somewhere impaired, so patient can start having erectile dysfunction. But if veins are, as per the aging process, we can understand some kind of conditions person is having, or some kind of issues are going on. Definitely, as per age, things are going to change, but pelvic floor has a big role. We can always keep strengthening the pelvic floor, whatever stage of the male or female is, and they can always create good grasping effect over the root of that penile structure. Because if this is a penis and the pelvic floor is like this, is the whole pen. So pelvic floor is like this cap, which is, or holding it here. It's like my hand. This is the pelvic floor. So if pelvic floor muscles are strong, and through now from here itself, the veins are also coming, isn't it? So if they are strong, they will put a more compressive force over the veins, and they will prevent venous draining during that, and the erection will be maintained as well as the sustained for longer time period. Sometimes if in like different new studies are like new studies, all the studies whatever has been conducted, they are saying that different regions of the world, they have a different erection period. If we are talking about the Asia in our side, so maximum erection can stay there for like 7 to 15 minutes. So that much of blood should be there, and that much of power should be there from the pelvic floor muscles. So we need a good strong power and the better endurance into pelvic floor, so they can sustain and maintain both. At least this is only what we can do as a pelvic floor rehab therapist. We can strengthen these pelvic floor muscles, which is wrapped around across the penile structure. And they're not only wrapped at the root, they are also covering the body, half of the body of the penile structure also. This is how the role of the pelvic floor muscles during sexual activities in a male. Very, very important. So these are the four important causes. The penile is a cylindrical organ, consists of three chambers. On the upper portion of the penis, there are two corpus cavernosas that are surrounded by tough but elastic layer of connective tissue, tunica albuginea. The third chamber is called the corpus spongiosum. It is located below the corpus cavernosas, and it's surrounded by a thin connective tissue sheath. It contains the urethra, the narrow tube that carries urine and the semen out of the body. These three chambers are made up of highly specialized sponge-like erectile tissue. Like, our body is having a subcutaneous tissue, or, epithelial cell, different type of tissues are there in our body. So this area, clitoris or the penile structure, they have erectile tissues. And they are filled up with the thousands of venous cavities, spaces that contain very little blood when the penile is soft. During erection, blood will fill these cavities, causing the corpus cavernosas to behave like a balloon, filled up expand like a balloon, and push against the tunica albuginea. They will put a pressure on the walls. While the penis will become hardened and stretches outside, the skin and the connective tissue of the penis will remain loose and elastic to accommodate the changes. The erectile tissues fill up with the blood during sexual arousal, production and producing an erection. Now, it's not only when we're talking about the erection, I have seen in my patient, and even the studies are also saying, when your patient, like for example, the spinal cord injury, complete spinal cord injury happened. There's no movement at all, but still your patient can show you erection, because erection is the process which is somewhere controlled by the brain. We don't know what stimulus brain can send. There are many things, even the smell, even the visual effect, any stimulus can start creating some kind of erection effect. So always the penile structure is never dead. Actually, it will always have some kind of uh, action going on, depending upon what the male is thinking at that time. So how does the erection occurs in male? During excitement stage. So there are different stages of male sexual functioning. When we're talking about male sexual functioning, there are altogether 4 stages of male. One is that desire is there. So want to have sex or want to have touch. Second is arousal. When this sensation or stimuli is there, and that can be any type of stimuli, then the body is going to go for excitement, and all the organs of wherever we have an erectile tissue present, all those organs are going to come into picture, and the blood supply will be very high towards that organ. During this erection phase, excitement stage, second stage, when body is going for arousal. The first stage is controlled by the brain, okay, that desire, and the brain can get the stimuli from anything. It can be the smell, it can be the visual, it can be the past memory, anything. Brain is active. Brain is sending signal to the body, and body is getting excited. When the body is excited, the heart will start creating the pumping blood towards the sexual erectile organs. Heart starts pumping blood towards sexual organ into the second stage. So means after brain, body physiology is changing, and erection begins with the sensory and mental stimulation. During sexual arousal, nerves messages begin to stimulate the penile structure. Impulses from the brain and local nerves cause the muscles of the corpus cavernosus to relax. As I told you, nitrous oxide release happens. That's why the corpus cavernosus are relaxing. Because of that, they will allow more blood to flow in towards that chambers, towards that spaces. The blood will create more filling. When it will be more filled up like a balloon, it will start putting pressure over the corpora cavernosus, making the penile structure more expanding, and we can see this kind of erected structure. The tunica albuginea, the membrane which is surrounding the corpus cavernosus, it helps to trap the blood into the corpora. Now we have this deeper fascia and the superficial fascia and the tunica albuginea. They all will start behaving like a ring. They will create a compressions just to create a sustaining this blood inside and sustain the erection for longer time period. So better health of your internal structures, better sustained erection. When the inflow of the blood reduces and the veins opens and erection stops. Now, till the time the flow will be high towards the erectile tissue, the compression will be maintained and vein will be compressed. But after that, when the blood flow is reduced, now that the pressure over the veins will reduced, and automatically the blood will start draining out from the penile structure and erection will go. In this stage, pelvic floor muscles, bulbocavernosus, helps managing blood flow to genitals by compressing the penile veins as a ring. As I told you, bulbocavernosus, pelvic floor muscles, they will grasp the penile root and the body, and they will create a ring, and they will help in trapping the blood into the penile structure, and it will help in maintaining the erection. So it means if the patient is having erectile dysfunction, so we have a role. We can strengthen the pelvic floor if they are weak. That is one of the causative factor. We can definitely help our patient. So this is how the erection happens, and it is flaccid penis is there. How does ejaculation occur? So we know that during the sexual stimulation, as I was telling you, there are 4 stages. The first was this one, desire, then excitement. Then the third is or like it's kind of stimulation, like touch. The structure requires touch of anything, okay, grabbing of anything, touch or grabbing. And the fourth is orgasm, okay. How does ejaculation occur? Sexual stimulation and friction provides the impulses that are delivered to the spinal cord and into the brain. Ejaculation is a reflex action controlled by the CNS. It is triggered when the sexual act reaches a critical level of excitement. It has two phases. In the first phase, the vas deferens, the tube that stores and transports sperm from the testes to that like what we are saying is what vas deferens contract to squeeze the sperm towards the base of the penis, and the prostate, it will up from this base of the penis, the sperm will move towards the prostate gland, and this seminal vesicles which is present there, they will release a lot of the semen, and the semen will come outside, and then we have a pelvic floor muscles also there, and the pelvic floor muscles will be released at that time, and the ejaculation will happen, and it will be unstoppable response of this kind of ejaculation because of everything, whatever is going on, either the CNS effect or the reflex which is sent, which is created at that time, and as well as the release of the pelvic floor muscles. They are also going away from the area. They're not putting compression. In the second phase, muscles at the base of the penis contract every 0.8 second, and now there are two stages, as I told. First, the sperm will release, and the second, the sperm should release with the maximum force. So when because sperm has to travel a long distance, we have a long penile structure around 18 centimeter. And if the penile is inside the vagina, and we need, if the female wants to get pregnant, sperm might have to travel by crossing the cervix of a female, this uterus, and it is going to cross the complete uterus and going to go towards the this fallopian tubes, that fallopian tubes where the egg is waiting. So we need a forceful ejaculation. So forceful ejaculation is going to help in more traveling for this sperm, so it can reaches up to the destination where the egg is waiting. And if that force is not there, so force is going to come with the strong contraction. Now, who is going to create a strong contraction? They are the pelvic floor muscles. So once the sperm will start getting released, that in the first phase, in second phase, pelvic floor will contract very strongly, the complete levator ani from inside, the complete pelvic floor, levator ani as well as bulbocavernosus, the muscle, the second layer of the pelvic floor muscle, they all will contract very, very strongly, and they are going to create that kind of compressive, they are going to generate a compressive force at the and at the base of the penis. Suddenly they will compress, and suddenly the semen will go with the force. So we need a strong pelvic floor muscles for the better, this kind of force to be generated inside. So semen can flow with the force. So sometimes when the patient is like the sperm, they're losing sperm outside and they're not able to travel all the way. So we can definitely strengthen the pelvic floor muscles, and we can increase this action of the muscles. We know that during this orgasmic stage, whatever pelvic floor muscles are creating is going to create the reflex that is not under the voluntary action. But no, it is another thing is, yeah, this is controlled by the CNS, but if depending upon how strong the muscles are, if muscles will be strong, the reflexes will be strong also. If muscles are weak, the reflexes will be weak. And so this is what we are calling it as a movement of fast twitch muscle fiber of the pelvic floor. So pelvic floor has a slow twitch muscle fibers as well as fast twitch muscle activities. So during orgasm, fast twitching is happening during that particular ejaculation phase. So this is the two things. Sexual arousal stimulates parasympathetic fibers from the sacral portion of the spinal cord to initiate and maintain an erection, as these fibers produce and release nitrous oxide, which then release smooth muscles in the walls of the arteries, and blood vessels become dilated, and more blood can enter inside the erectile tissues. The increased blood flow and widened blood sinuses causing erection and compressing the veins that drain the penis, which slow down the blood outflow, helps to maintain the erection. Once sexual stimulation has ended, the arteriole will become contract, and the smooth muscles within erectile tissue will contract, will also start contracting also, because nitrous oxide release will be not there. The blood sinus will become more smaller, than thus relieving the pressure out from the veins, and whatever blood is there, it will drain slowly outside, and the penis will return to the relaxed normal stage, flaccid state again. So this is a simple slide which you can take a screenshot, and yeah, that was the arteries and the veins, and the role of arteries and the veins into the erection, and some role of the pelvic floor, which I explained. Now, when we're talking about the nerve supply, so the penis is supplied from S2 to S4 spinal cord segment. Like the same pudendal nerve is going to supply actually this kind of structure, pelvic floor also, and as well as the penile structure also. But there are other hypogastric and the hypogastric nerves are also going to come. So there are many sensory and sympathetic innervation to the skin. We have a skin, we have a glands, which is supplied by dorsal nerve of the penile, a branch of pudendal nerve. Now, when we are talking about pudendal nerve, I'll give you more detail when we'll understand the pelvic floor muscles. This pudendal nerve is having 3 branches. In this image, you can also see these are the 3 branches which is gonna go into. One will go towards that anal structure, which is the anal branch. One branch will go towards the perineal body of a male, which is going to supply the superficial pelvic floor muscles and deeper pelvic floor muscles, middle pelvic floor layer. And then one branch will go towards the penile structure, which is more a dorsal nerve of the penile structure. So these are the 3 branches which is gonna go. Some branches are gonna go into the, before entering into the perineal body, they are going to enter into the scrotum also. So sensation from all these external genitals are going to carried by the pudendal nerve. And S2, S4 is important region from where the sacrospinal nerves are coming. So whenever the patient is having some kind of pain sensations or some kind of nerves are, there's no sensations are there, painful sensations are there. So you can apply tense over the S2, S4 region if the painful sensations are there. And if the patient is having no sensations are there, so we can again apply galvanic stimulation or Faraday stimulation around the sacral region. We can go for a sacral stimulation to increase the sensation or to help in decreasing the pain which is going on into the pelvic floor or sometimes into the penile structures also. Okay. Parasympathetic innervations is carried by cavernosa nerve from periprostatic nerve plexus and is responsible for vascular changes which cause erections. But the sensations are going to go towards the brain, isn't it? So this was the external penile. And if you lift the penile up and if you lift the scrotum, then you will feel some kind of this base downward, this kind of space, skin. And if you touch the skin, you will feel some kind of hardening into that skin. Actually, you are touching the root of the penis. Beneath that, we have a root of the penis. And that is covered by these muscles. This is the bulbocavernosus muscle. From the side, we have ischiocavernosus muscle is also coming. So we can palpate the ischial rami, and you can keep going towards the ischial tuberosity. So easy is that you palpate the ischial tuberosity first and go upside, and by feeling this bony surface. From this bony surface, the muscle is originating. This is the ischiocavernosus muscle. And this muscle is again going to merge with the bulbocavernosus on the top here, and they both will encircle the complete penile structure. So there are 2 ischiocavernosus and there are 2 muscles actually, but they are as a one, they are serving as a one, as a ring, bulbocavernosus. So this is the one bulbocavernosus, and these are the 2 ischiocavernosus. And after that, this is again perineal body is present. And now let me show you, let me just explain you first what you're gonna, how many structures you're gonna see here. So assume that your patient is in front of you. So first there will be pubic symphysis, and After pubic symphysis, there will be the second part you will be visible is the penile body. Assume that you have lifted that up. Then the scrotum. So you lifted the scrotum up also. After the scrotum, you will feel just beneath of that, the body of the penis, fourth. After that, this is all skin which is covering it, but upside is the body of the penis. And then downward, we will have a perineal body, another substance which is harder into the center, penile body. And from the penile body into the penile body, many muscles are merging, coming here, inserting here, they're going out from here. So you can see the bulbocavernosus is originating from the penile body. It is going up and it is inserted into the body of the root of the penile structure. So origin is from penile body and insertion is into the root of the or the body of the penile structure. Same way, ischiocavernosus, the another muscle which is coming from the ischiocavernosus, this muscle is also coming. Origin is from ischial tuberosity, but insertion is into the penile body. So penile body is very important point into center. And now from penile body, another muscle is going backward. That is the external anal sphincter. So you will feel behind, we have this anal canal. And now the muscle is coming from here. It will lap around the complete anal canal, two muscles, right and left external anal sphincter, that will merge with each other, completely encircle the whole tube, 3.5 centimeter long, and it is gonna insert into another body, this white substance, connective tissue here. So over here, this the anococcygeal body is present. So now how many structure? 3 was the scrotum, 4 was the root of the penile structure. 5th is a penile body. 6th is that anal canal. 7 is anococcygeal body. That is the area which is gonna connect that external anal sphincter and with the coccyx. At the back, we will have a coccyx here. So this is a kind of one tissue, strong tissue. So 2 bodies are present, perineal body and anococcygeal body. And after that, you can palpate the coccyx of a person. Okay, that is, so this is 5, 6, 7, 8. 8 structures all together we have to see when we are traveling from front to back. Okay. And these are the 2 muscles which is present here, bulbo and ischio. We'll understand that in upcoming slides. Let me have a break, everyone. I'll see you after 10 minutes. If you have any questions so far, whatever we understood, like, whatever is as per my limit, I will able to help you. Okay, whatever understanding I'm having. So definitely you can ask a question. You can write down in the chat box in this 10 minutes of break. I'll see you at 11:20. Okay, how the session going on?
The session is going good, Dr. Patel. Unfortunately, I missed in between some portions as
I
my
recorded. I recorded.
both of my kids are home, and then my daughter.
So we understood about external genitals, that penile structure and the scrotum, and even we understood bit of their functioning also. And now let's understand the internal organs. So this is a urethra, and the urethra is going to attach with the prostate, and then we have a bladder on the top. So the female, all the participants who were with me in other sessions like female pelvic floor rehab, so they understood the bladder already, but it might be new for some of you. So let's just understand bladder. Male renal tract. So it's same like a female renal tract. It's only one difference, the urethra. The urinary tract is responsible for the production and storage and passing of urine. We all know about this. And the whole tract is having these 2 kidneys on the sides. They are going to attach through the ureters in with the bladder. So into bladder itself, there are 2 openings present here, which is that these are the opening of ureters. So 2 ureteral opening right and left. And then we have another opening into the bladder, which is the opening of internal meatus. So There are three openings is present into the bladder, and they are creating the trigone shape here. And this is the ureters of other side and the kidneys. Kidneys will keep doing the filtration. It will keep through going down through these tubes, and bladder is gonna fill. It's gonna create. It's like a reservoir. It's gonna this like contain the urine inside, store the urine inside. And then urethra is there, and through the urethra, whenever male wants to void, pass the urine, and then the urine will go outside through the urethra. So this is the whole renal tract we all are already aware about. The two kidneys lie at the back of the abdomen behind your 12th and 13th rib. They produce urine by filtering unwanted substances from the blood, the urine. So you can just take a screenshot of that. Then we have a semen is made into the testes, and from the testes, it is going to pass up through these two tubes called vas deferens, and it is going to store into seminal vesicle, which is a small gland present between the bladder and the rectum, and behind the prostate also. At ejaculation, the bladder neck closes and the semen passes down the urethra and out of the penile structure. So this is simple understanding, but through these ureters, you can understand the bladder. There are many conditions where we are going to help our patient. Assume that patient is having some kind of inflammation going on with the bladder. Interstitial cystitis is the one condition where the bladder can go for this kind of swelling. So, and that can all affect internal mucosa and all the action of the bladder. There might be something which can happen with the middle layer of the bladder, detrusor muscle, the nerves which is supplying that, so we can give a help to that patient also. And if something happened to the outer layer or the complete whole layer, so bladder is very important organs to understand. So when we are talking about the bladder, male and female, the same system is there, and renal system is there, but male bladder size is bit larger than the female bladder size, because they have more space there, isn't it? And male organs are also somewhere bigger than the female organs. So this is the internal physiology itself. So when we are talking about the male, like you can understand the itself, the size is big. So they can, the holding capacity or the amount of urine they can hold will be also more, isn't it? So that's why if we say that as a female, we can hold around 350 to 400 ml urine in our bladder, male capacity is more than that. They might hold up to 600 ml. So because of that much of size inside. So, and this is the one factor why female are going for urination. The frequency of urination female is more. It can be 6 to 8 times because the size, according to the size and the storing capacity. And the same way when we're talking about the male, that storing capacity is more. So yeah, so their frequency can be less. So we can say that 4 to 5 times male are going for urination, which is a normal frequency for them. And female, it can be 6 to 8 times. So the size matters. When we are talking about that whole bladder, so bladder is like a balloon, which will again deflate and inflate, and the size is going to change according like during voiding, when will pass the urine completely, it will be completely kind of compressed structure, and when we'll keep filling it going on, so it will expand. And it is a hollow muscular organ. When empty, the bladder is about the size and shape of the pear, and it lies into the pelvic cavity just behind the pubic symphysis. And but once it start getting filled up with the urine, it will start getting expanding. It will go towards the abdominal cavity also. So when it expand, it will put pressure over the internal abdominal organ. It will move the internal organs upside all the intestines, and it will go towards the abdominal cavity also. The bladder has, when we're talking about the bladder is having 3 openings, 2 openings from the ureters, right and left ureter openings, and one is the internal urethral opening also over here. So urethral opening and 2 urethral opening. So these are the 3 openings, and if you join them together, we can say this is a kind of trigone type of structure is present, where the openings are somewhere present. And this whole organ is having three walls. One is the outer layer, which is a peritoneal layer, that which is going to separate it from other organs. Then we have another layer, middle. This is the middle, which is made up with the smooth muscle. And this is the detrusor muscle of the bladder. And you might have heard of one condition, hypertonic detrusor or detrusor hyperactivity. So neurogenic bladder. So those are all are the conditions which is like detrusor, which is going to affect the detrusor muscle specifically. So this is a smooth muscle which is under the control of the brain because of the nerve endings which is coming into that, supplying the area is controlling the activity and behavior of detrusor. So they again they create a series of contraction and relaxations whenever we required. So when we want to go for, the feeling is going on, the detrusor is going to relax, and it will create more space, so more urine can store. And when we are going for avoiding, the detrusor is going for contraction. Contraction of the detrusor is begin, and that is going to help in moving all the urine out of the bladder outside. So contraction and relaxation is the important activity of the detrusor, but that is an involuntary action which is taken care, which is only controlled by the CNS. Now, just more in, and this detrusor is supplied by the nerves, and they are more responsible. Sometimes the nerves which is supplying the detrusor, they can show you different behavior, and it can suddenly the detrusor can go for contraction because of those kind of nerve damage and nerve pathology. So they might start giving sudden detrusor contraction or sudden spasmic kind of effect. So in this case, bladder might fail to relax as well. And spastic bladder, we can say, or it can be the detrusor, we can also term it as a neurogenic bladder. So whenever the neurogenic bladder comes in our mind, it means the nerves which supplies the detrusor are not functional. Something happened with them. So this is very, very important layer of the bladder, detrusor, and it is a smooth muscle. And just very internal layer when we are talking about of the bladder, that is again every organ of our body, whatever organ you name it, they have this kind of three layers: outer peritoneal, middle smooth muscle, and more inner is a mucosal layer. So mucosal sheath is present throughout this area. So assume the room where you are sitting right now. In this room, this internal, all this color and the paint is having a the presence of the mucosal sheath. And they have a different kind of skin present, and different type of cells are present into that, different type of receptors are present into that particular level. Nerve endings are also there into that part, which is going to send a signal to the brain that we need a space, so it will keep relaxing and keep contracting. So we have a nerve receptors are also present into this particular area. And this whole internal, the completely three-layer detrusor, as well as specifically the mucosal layer, more inside the mucosal layer, they are under the effect of hormones. Specifically in female body, whenever we are talking about, so this internal bladder has the effect of estrogen is there. So estrogen receptors are present there. So more estrogen will be there in a female body, better estrogen will be there, better bladder health will be there. Once we have a lack of estrogen, that particular stages in our life as a female, during lactation, during periods, when our periods are going on, or during the luteal, during that what we can say is menopausal time period. So there, if estrogen is down, hormonal imbalance is going on. In case of PCOD also, so they can affect the behavior of bladder. Okay, and even the whole urethra is also under the effect of estrogen hormone in female body, but male not that much. So the effect of hormones are not there. So now when we're talking about these three, outer, peritoneal, middle detrusor, and inner mucosal, so they all are working as a team whenever we want to store urine. So they all are going to go for expansion. And this internal layer, the mucosal layer, we have a presence of sac-like structures, small, like umbrella-like sacs are present there. So they will expand and they will give more, the surface area of the bladder will expand as well. Okay, like this, the skin inside the skin is present. Now, when we're talking about the whole skin, the umbrella-like sacs presence, they're not present into the area, the level where ureters are coming. That particular level or this internal, this meatus also, urethral meatus, they are not present there. The skin is different. It's a very smooth skin, smooth layer is present at that area. And we don't have stretch receptors present at this trigone of this bladder. So always this part, because there's no stretch receptors, whenever urine will stay into this part or any liquid will stay into this part, the sensation will not be given, not be transferred to the brain, because those kind of nerves are not there, which is going to send signal to the brain that something is there and we have to go for voiding. So that kind of urine, which is always going to stay into this trigone area, that can be approximately 50 ml of urine. And this is what we are calling it as a residual volume of urination, like which is always present. If the residual volume is present more than 50, so after the urination, it means that something is not good. The user is not able to contract completely during the voiding. So some kind of issues are going on with the bladder. Okay, and if the volume is less than 30, again, we can say that something is going on with the internal mucosal skin. Some kind of issues might be there. So when we're talking about this internal mucosal layer, so sometimes infections can come and it can spread into the bladder and they can start creating the inflammation to this mucosal layer. So assume that if this mucosal layer, this inner layer will start getting inflamed and because of any reasons, so it will be hard for that, it is going to give painful sensation to the person even during the feeling. When we are talking about the urine is acidic into nature. So when urine will come from the ureters and when inflammation is going on, that inflammation will create a more shortening of the passage around the ureters also. Ureter openings will also get inflamed. Because of that, when urine will come downward, so every time when the urine will come, it will build the painful sensation for the person. So continuous pain, pelvic pain can be present in the person. It can be male or female in case of inflammation. Orifice can start getting narrowed, or might be the area can be narrow because of the edema or the swelling, whatever is going on into that. It might start creating less urine into that bladder, and urine will start staying into the ureters, and it is going to create it's going to start creating more pressure. It can create more pressure over the kidneys also. So this can happen if any inflammation or any things are going on into this particular interstitial cystitis. Sometimes there can be some kind of stone particles which can come from that what we are saying is the kidneys, and small particles, they can also create some kind of obstruction to this kind of tubes, and it can again create some kind of issues with the person, and they can have those kind of renal dysfunction problem with the storing and the filling phase. And this can happen into this particular area. Urine is made into the kidney and travel down to the two tubes called ureters to the bladder. The bladder expands like a balloon or sac, and it can collect along like more urine, like ml of urine in a male, approximately 450 to 600 ml. So whenever we are talking about the behavior of the bladder, now there will be one capacity, there's a capacity of that. After certain capacity, it has to send a signal to the brain that I'm full, and then we need this voiding, and micturition is one process which is very important to understand. So always whenever we have this kind of sensations, there are two stages. So first, till the time bladders keep getting filled up, it will up to the half of the level, when it will be like, for example, the whole bladder. It's a whole bladder. So the whole bladder is filled up with urine, the completely. So it is gonna put stretch the over this internal layer. The sacs are gonna expand. So this expansion of the sacs, they required some kind of signal, isn't it, from the brain? So this is the first voiding sensation. So the whole bladder is full. It is going to send a signal to the brain that we are full. Now brain has to decide that what to do next. Brain will send a signal to us, and by, like, we will get this sensation that my bladder is full. But that is a first sensation, first urge, what we will found, not urge, first voiding sensation, what we will get from the brain. But at that time, our bladder is not completely full. There is still space when the bladder is going to expand now. If I miss that particular signal and I'm busy, I feel, no, I don't want to go right now, because then I might start be with you, I might stay with you. So now again, this is going to send a signal to the brain, is going to send a signal to the detrusor muscles that for the relaxation. So in this case, detrusor will start relaxing. And once the detrusor will start relaxing, we'll get more surface area into the bladder, because the wall of the bladder are now expanding. So we can store more urine. So this process, expansion, will keep going on until the bladder will, the detrusor will expand up to its last limit. Once the bladder will stretch out completely and there's no space, it can now stretch more than that, then it's going to send a signal to the brain that we need to void. We don't have any room to collect the urine further. So this is the second signal brain is going to send. That signal is going to send to the brain through this kind of nerve receptors, and then brain will automatically relax the internal sphincters. So the urethra is having around this bladder neck over here, this part, particular bladder neck, we are saying is bladder neck. Around here, we have an internal sphincters. Internal sphincter, you can assume that internal sphincters are automatic of the urethra, actually, the part of the urethra. So urethra is is a tube, and all the tube of the urethra are compressed with each other. The walls of the tubes are they're touching each other, and this they have some kind of this internal sphincter action, which is compressing the urethra together. But automatically, the nerves will send a signal to the urethra, and urethra will relax. So this is what we are saying is the internal sphincters are open. So urethra is open now, and some urine which was keep putting pressure upside over the detrusor, and that's why the detrusor was sending the signal to the brain. So now some urine, some amount is going to go downward into the urethra, because now urethra is open. It's relaxed. So once the urethra will relax up to 5 mm, it's up to only 5 mm space is there. So once it will relax, some urine will go down as per the gravity also, as per this moment also. So whatever pressure was going on over the detrusor, that pressure will be released at that time, or patient will start getting up, and depending upon, now still I want to void, or I'm still busy in something. If I still busy in something, so what I'll do, I know that my internal sphincter body has this kind of sensation, the urge to pass, but no, I can't go. I have to hold. The urinal is not around me. I might be somewhere outside. So at that time, my external sphincters, like which are the pelvic floor muscles, so they will create a contraction. Now the brain is sending signal to both internal and external sphincters to relax, but voluntarily we can create we can stop the relaxation of these external sphincters. Even we can generate more contraction. We can start creating squeezing around that area by different type of action. We might cross our legs, because when these kind of sensations are there, or we might add extra activity, or automatically our pelvic, if the pelvic floor muscles are strong, we can hold that urethra and urine will not go down. Already the urethra is having urine, but we are stopping the urethra by compressing with the pelvic floor muscles. It cannot go out into the whole canal. the passage. So this how, if the patient is having a strong pelvic floor, we can hold the urine, and if the patient do, and we can maintain the continence, and by squeezing it. And if the pelvic floor muscles are weak, so that is the case when we see that urine, we cannot stop the urine, and might be urine can go all the way into the urethra, and patient can start getting this kind of leaking. And this is the incontinence problem. When we fail to maintain the continence, still I want to create this continence, I want to create this kind of hold, but I'm not able to hold it because of the weaker pelvic floor muscles. So pelvic floor muscles has a big role in holding the urine, sustaining the urine, and pelvic floor should have that kind of sudden action and slow twitch muscle fiber, like endurance should be also there. So it's for long time, minimum 10 seconds we need whenever we have this kind of sensations to pass the urine. We need minimum 10 seconds to reach to the washroom. And whenever we are outside, we might need more time. And so depending upon how strong your pelvic muscles are, we can always have this kind of hold on our voiding. So if we fail, we call it as a like pelvic floor dysfunction. You can understand that how it is, the muscles are important. So this whole bladder is present. And now the bladder is having, as I told you, this kind of trigone, and this kind of sacs are present everywhere. They will expand and they will accumulate more urine. And the trigone will, they don't have any stretch receptors, so there will be always some amount of urine will be there, approximately 50 ml. And this is the particular area I was talking about. This is the internal meatus. This is the external urethral meatus, or external urethral orifice, or internal urethral orifice. And same way, these are the sphincters, internal sphincter. Internal sphincter, like same detrusor muscle, we have this smooth muscle present around the detrusor, the middle layer. Same detrusor muscle is present over here also. So it will contract, it keep creating contraction. But once detrusor will relax from here, more relaxation, same way, this signal can be sent to this particular part by the brain, and this site is gonna relax, and urine can start flowing downward into the urethra, this particular part. Which is a prostatic urethra. The urethra is crossing through the prostate. In a male, just base of the bladder, the prostate is starting. So the part of the urethra which is crossing through the prostate, we are calling it as a prostatic urethra. And then just the urethra will, the prostate will finish, and we have a pelvic floor muscle. These are the pelvic floor muscles which is all attached here. Now this is the urogenital diaphragm, we are calling it. So pelvic floor, the urethra is passing through pelvic floor muscles, and that it is going to enter into the penile body like this, and the passage is all like that. So when we are talking about the urethra of a male, it's long, quite long. It is 18 to 20 centimeter length is there. And function we already discussed. Whenever we are talking about the urethra, it's not a straight urethra in a male. It's a curved urethra like this. It's because penile structure is passing through different areas, isn't it? So now this is the prostate here. This is the bladder. So prostatic urethra will be there. Pelvic floor muscles will be there. And then there will be one kind of, this kind of angles, it is going to curves they are going to create. So every curve, the complete internal part here into urethra, they have a different bacterias are lying, and they are keep maintaining the internal, what we can say, ecosystem inside this whole urethra also. So assume that we have those kind of, I will not say it's kind of pH level, isn't it? So now if any kind, these are the curves, this is one curve, then this is again a curve. So whenever any infection happens to the male penile structure here, if any infection happens, so this infection, it will be hard for this bacteria to travel all the way up to that, bladder. So that's what, because the any infection has to travel long area, and this is the acidic environment inside, which is maintained. So now if any bacteria will start growing, it will be killed by this internal urethra. So and the bacteria has to travel along also, and it has to cross every angle, every this kind of curves. And at every cusp, it will be killed by whatever internal ecosystem is there. So that's why UTIs are not common in male. This urinary tract infections, they are not very common in male because of this kind of longer structures. And they are very common in female because of the shorter, just a simple shorter, urethra. So if any bacteria infection will start here, it will directly go to the bladder. So that's why they are more common in female UTIs and they are less common in male. So they have a more protective structures. So this is how they are prostatic urethra, and they are having this bulbar urethra when it is crossing through the bulbocavernosus muscle. Then we have this pendulous urethra when it is crossing through this whole body of the penile structure. And then we have this fossa navicularis and meatus externally outside. This is the external urethral meatus, which we can see externally. And the course when we are talking about it, the urethral canal is passing through that anterior urethra, posterior urethra. Posterior urethra is subdivided into the bladder neck and prostatic urethra. Anterior urethra is then subdivided into the bulbar urethra, pendular urethra. You can see it like that, isn't it? This is the posterior part, which is going to divide into around this bladder neck is starting, and then prostate. So two divisions are there. And in this one, anterior, there are further divisions because we have muscles are also there, pelvic floor muscles. They have to cross that. Then we have, you can understand this whole body, penile structures. So pendulous means complete penile structures has to cover cross, and they will enter into this particular outside glands. So, and then externally meatus. Course emerges from the neck of urinary bladder, enter into prostate, passes through the urogenital diaphragm, enter into the bulb of penis, then the body of the penis, and then finally open at the tip of the glans of the penile structure. This is the urethra of a male, which is completely all curved, and that was the bladder. Third is anal. Anus, not anus, it should be rectum actually. I'm so sorry. Rectum and anal opening. Okay. Okay. So the rectum is so this is the posterior aspect. Now we have to cover prostate. I'll cover prostate tomorrow. Today, let's just cover anal, rectum and anal opening. We all know the rectum is the last part of the colon, which is coming here. So this is a longitudinal layer of the colons, which is ending here. And then we have this rectosigmoid junction, and this is the whole rectum. And the feces will keep coming. It will keep storing into the rectum, into this particular area. Our stool is present here. And this whole rectum is subdivided into 3 zones, upper, middle, and lower zone. Depending upon, in all the zones, there are different type of skin is present, skin layer is present, or mucosal layer is present. Now, in this particular rectum also has this kind of 3, outer peritoneal, middle, some kind of smooth muscles, which is going to contract and relax. And then we have more inner mucosal layer, which is present inside, which has this kind of mucosal activities, and this kind of secretions are going on, and too much of vascularity, blood supply will be there, ending, arteries will keep ending into this particular area, veins will keep ending into this area. So there are nerves are also attached, so they will keep sending signal to the brain as well. So this is all the 3, and every zone has a like different particular, we can say appearance, like palpations, as a physical therapist. If you want to understand into this, as soon as you enter into, after crossing the anal canal, you enter into the lower zone. Over here, the pelvic floor muscles are present. Into middle zone, this is the prostate is present. And as soon as you are leaving the prostate and going more deeper, then the bladder is present into the upper zone. This is how the levels are there into that area. And they have a different folds are also present in the whole area, because they have to maintain that internal anal pressures. So we have high pressure inside because internally the stool is having a weight, and we have to hold this stool inside. So it should not be just completely straight lines. The body is made into that way that we have different type of folds. So the stool has to just cross through these folds. And then more downward part is more important part. Lower zone is very important when we're talking about anal region. And because more number of, this kind of internal sphincters, external sphincters, veins, arteries, different type of many nerve, even the vagus nerves, they are ending here. So somewhere they are going to give more sensations whenever we are going to touch this whole inner area. So sensations are very, very high in this particular lower zone. So when we are entering our finger inside also, the patient can, might feel some kind of difficulty and discomfort. They can show you some kind of discomfort and different sensations. And the skin is hypersensitive when you are inserting your finger into the lower zone. So we should be very careful. So the rectum is the last part of the large intestine, 10 to 12 centimeter long area, which is going to store the stool. The anal canal refer to the last portion, and it consists of two tubes, internal and external sphincters. The external tube is made up with the external sphincter and uh, the pelvic floor muscles, and external sphincter is innervated by somatic nerve. The internal tube is composed by mucosa, submucosa, internal sphincter, and they have this longitudinal muscles. When we are talking about the pelvic floor muscles, they are rounded circular muscles, and longitudinal muscle fibers are also present into that. But this internal sphincters is again a smooth muscle, isn't it? And it is innervated by autonomous nervous system. These sphincters are very, when we are talking about the whole downward lower zone, over you can see in this image, this is the expansion, further expansion of the smooth muscle is extension of the smooth muscle is going on. This smooth muscle only is behaving as an internal sphincter. The smooth muscles will keep keep closing the anal canal together. Anal canal is a canal, but this canal is this canal is not open like that. The canal is like closed, like a condom. It's collapsed always. And this collapsion is because of the smooth muscle, and which is again taken care by the brain. Till the time brain will not let this muscle to relax. This will not relax. They will keep contracting, and this contraction is important. And this contraction is going to maintain high pressure inside. So now we don't want the stool should come from the rectum and directly touch the anal canal, the area which has more sensation into that lower side. So we don't want any sensation. If any sensation will come, we'll feel urge that we have to go for voiding. So stool should not come into this zone. So we have those kind of special arrangement in our body, like we have the part of the puborectalis, this muscle, what we are saying is levator ani, puborectalis muscle is gonna pull this rectum anteriorly, so that rectum will it's going to create a kinking to the rectum. For example, I'm a rectum, so something is holding me in one direction. So rectum will be pulled. So whatever is there into the rectum, because of this kink, that rectum pressure, that will not come into the anal zone. It will not enter into the anal zone, because into anal zone, there's a high sensation. Many that kind of nerves are there. It's going to keep sending signal to the brain that, oh, I have an urge to pass. So we have to keep avoiding that pressure. And in this particular region, into upside of the anus, we have high pressure. So this high pressure, you can understand if the high pressure is there, so that particular site of the anal canal, we have arteries. So arteries are keep moving the blood, but because of the pressure, arteries will be compressed, isn't it? And then we have a veins also. Veins will be under compression also because of this high pressure. So that's why we are more prone to develop hemorrhoids and swollen veins into this particular internal hemorrhoids and these particular sides as compared to other body in our other body parts. This anal region is more prone to show you this kind of congestion into that particular area because of the pressure. So pressure is important, and pressure is gonna create a contraction of this smooth muscle. If they will be contracted, it means stool no particle will come downward into the anal canal. If the particles will come into the anal, and this pressure is high pressure, is gonna move the stool upside into that particular upper zone. No, it will not let it go down. So whenever we are inserting our finger inside the rectum, so sometimes you feel some kind of we always feel some kind of resistance. Like patient, we feel that patient has too much of that kind of we will sense resistance from the anal canal into this penetration or inside this insertion of the finger. It will try to throw your finger outside. It will not pull your finger in, because the anal area and the structure is not designed in such a way that you can go inside. It is designed in that way that you can throw out. So the pressure is high there, and the pressure is maintained by this internal sphincter completely, and that is again controlled by the brain. So we cannot control. If internal sphincter is damaged, and because the nerves which is supplying the internal sphincters, if they are damaged, it will relax. If it is damaged, so it will be relaxing, weaker internal sphincter. If they will be weak, so mean the pressure will not be maintained. So in this case, the stool particle, and if the pelvic floor muscles of the person is, the puborectalis muscle is also weak of the patient, stool can come directly into the anal canal, and then it is into by crossing this zone, it can come into the canal passage, and into the passage if the stool will come, then who will be who is gonna get pressurized, because who has to work extra? Pelvic floor muscle has to work extra, external anal sphincter. So they might have to create extra contraction. They will be strained pelvic floor, and for more longer time period, if they will keep doing extra work into this holding, so they will become loose in the long run also. And at the end, if internal sphincters are weak, it is going to lead to the weakness of external sphincter also in a long run because of this overuse. And and after that, might be patient will start showing you those kind of fecal incontinence, and not able to hold that gas inside, and passing of the gas, those kind of sensation inside. If the internal sphincters are failed to relax, for example, something happened to internal sphincter, it failed to relax. So what will happen? We cannot pass, we can't defecate. So it will be blotting and those kind of constipation, and that can also comes into picture. So internal sphincter is something which is not under our control. We can definitely control the pelvic floor muscle, external sphincter. We can relax them, we can strengthen them, we can make them coordinated whenever it is required, but we cannot do anything with the internal sphincter. So whenever your patient is coming to you, always check the reports, and whenever it is referred by someone, or if it's not referred by the urologist, so send your patient to the urologist. We need to see the status of internal sphincter. They should be healthy. If they are not, if they are something happened with the internal sphincter, so we are not the right people to help our patient. We can, if we'll keep strengthening the pelvic floor and in incontinence problems, fecal incontinence problem, but her internal sphincter is damaged, or his internal sphincters are damaged, so our treatment is not going to help the patient. So it's better to go for this multidisciplinary approach. So we will also take care of, we'll check the pelvic floor muscles, we'll try to strengthen the pelvic floor muscles, but simultaneously, patient require those kind of, support. Might be, whatever support that colorectal surgeons are going to, colorectal people, gastroenterologists are going to support them. So we need to refer our patient, and we cannot do anything with the internal sphincter damage. It can be the internal sphincter of bladder, or it can be the internal sphincter of rectum. It is not our role. Yeah, external sphincter, definitely it is our role. So when we are talking about the anal canal, so another thing about anal canal is the presence of this particular structure. We are calling it as a pectineal line. So in every structure, every canal, you might be able to see this kind of pectineal line is present. This kind of folds are present on the halfway of anal canal, or this is starting of the anal canal, actually, we can say this. So this anal canal started, and these are the internal sphincter over here, and in this downward passage, we have these veins, arteries, nerves, everything is there. And now over here, we have this kind of folds present. This kind of folds present. You can say over here, this is a kind of dentate line. You can say it is a dentate line or pectineal line. You can also name it like this, pectinate line. This is written here, pectinate line or pectineal line or dentate line. So this is gonna, what is the significance of this line is that it is going to divide the anal canal zone. Upside, there will be different skin, different nerves, and different pressure. And downside over here, when it's going to come in connection with the external zone, external environment, the skin is more tougher skin. And there's this anal around the anal margin. So it is more tougher skin, and even that pressure is also not there into that particular part. And even veins are also very less into this is not too much of blood supply and too much of venous, veins are present. Everything is more pressure is always there into upper side, this particular area. More presence of everything, internal sphincter, internal pressure, veins, arteries, everything, and nerves, more sensitive nerves, sensitive skin. They all are into upper zone. And downward zone is not that much pressure is there. So whenever we are saying that this pectineal line is this way.
Dr. Patel.
Yes.
So earlier you were saying that the lower part, I mean the anus usually has a lot of high sensation.
Mhm.
Um,
Anodum,
so,
we call it as an anodum area. This is the anodum area of an anal.
but it is not the part of rectum because it's showing rectum,
It's
and
not
the
part,
anus is just the,
it is not a
sorry.
part of rectum. It is the anal part. Like some part of the rectum and lower part of the rectum actually. Just a lower zone, but it's a part of anus.
So when we insert the finger, the initial, usually we ask the patient to breathe out and then we insert the finger in, right?
Hmm.
So when almost the DIP goes in, you
Hmm.
know,
Hmm.
then after this area starts, or how much deeper this area we would feel?
Half knuckle, when you're crossing the half knuckle and your one finger is inside, like you will feel that you're moving your finger like this. So your completely half knuckle will be in, then you are crossing, then complete knuckle will be inside. So means you have crossed this zone like this. So half knuckle will up to that particular sensation. So after inserting, if your half knuckle is inside, then you will feel the pressure outside. It will push your finger outside. We'll start
Yeah.
feeling this pressure. Once we'll start feeling this pressure, it means we are entering into that upside zone, upside line, upside to this pectineal line. Okay.
Okay.
Till the time you're not feeling pressure, you are still outside. Once you start feeling pressure, it means you are entering inside. Because pressure means anal pressure is there, isn't it?
So
Oh,
the lower part doesn't have much, but the upper part of the pectineal line is more sensitive, where
very
more.
sensitive. Yes. Yes.
Okay.
And this is what you will understand through this slide. Anal mucosa, we're talking about anal canal. We are also saying that this is an area this is the anoderm area. The upper part of anorectal ring, the rectal mucosa, contains shallow glands which secrete mucus. If the mucosa would prolapse through the anal canal in such condition, sometimes, because of this high pressure, and it might, and if the pelvic floor muscles are even weak, if the patient is having a weaker pelvic floor muscles, pressure is very high. So this mucosa can start coming downward. If you are a part of WHPT group, have you seen one case was sent by Dr. Gada from Mumbai? She showed one video of one kid, 9 years.
Yes.
So
Yeah, yeah, yeah.
have you saw that mucosa was outside?
Yeah, yeah, yeah.
So that was this internal part of the anal structure was falling downward because of the pressure which is all created internally, constipated stool, or it might be this high pressure inside and weaker pelvic floor. So the prolapse can happen, the internal skin. Okay. So
Okay.
and if the mucosa would prolapse through the anal canal in such condition as rectal prolapse or prolapsed hemorrhoids, sometimes it's not only the rectal mucosa, it can be the hemorrhoids. Because of this extra pressure, the nerves will be, the veins will be compressed and they will fail to return the blood back. So some part of the blood will be always into these veins, and as per the gravity, might be it will keep filling with the blood, but they will not, they will fail to create a venous draining. So they might show us some kind of internal hemorrhoids or piles. So whenever the hemorrhoids and piles are above than the pectineal line, upper side of the pectineal line over here, these veins are swollen. We are calling it as an internal hemorrhoids. And if the hemorrhoids are swollen below this pectineal line, so they are external hemorrhoids. Now we can understand this above than pectineal line, high pressure is there. So this is going to give more compression to the swollen vein. It will show pain to the person. So pain will be the first symptom. And another thing is these veins will be swollen. They will also create some kind of obstruction when they will try to pass the stool as well. So narrowing of the canal it will create, and the pressure will be always there. It will all putting pressure over the veins. So veins can even lacerate because of the pressure and because of the stool. And this is the reason why some patient can see this blood into the stool. When the veins are pressed because of this high pressure and as well as this hard stool, and laceration can happen into that internal swollen veins, and it will give too much of pain for the patient, and it can give them difficulty into defecation and narrowing of the stool, or painful defecation, or blood into defecation, those kind of irritation into that part. And after even it will be incomplete voiding can be also be shown into those kind of patients. And another thing is burning kind of sensations. So they will show you. They are more common when the hemorrhoids are pressed and they are upside to this pectineal line. Below the pectineal line, we are calling it the swollen veins as the external hemorrhoids. Now you can understand this part, we don't have a pressure, and that is not upper side. We have more sensations also because of this presence of anoderm skin tissues, which has more nerve endings. Now, lower part, we don't have that, we have less sensation as compared to inside. And the nerves are also not compressed. So this external hemorrhoids, 80 to 85% females who are pregnant and who are mothers, they have, I have seen in my practice, 85 to 90% of females are having hemorrhoids, external hemorrhoids. And they're symptomless, no problem. They're not giving any issue, no pain, no irritation to the person. So most of the people are living with it without any symptoms, but internal hemorrhoids are more painful. You can understand now why. It is because of the pressure, which is always maintained by the internal sphincters. The hemorrhoids, it would become wet anus that inflamed chronically and secrete mucus excessively. Now we have many glands present into this upper side, which will we have more arterial supply also. Blood supply is also very, very high. So because of this high vascularity, glands will become more active. When they will become more active, they will keep secreting a lot of mucus also. And our internal mucus is most of the time wet mucus. And these internal hemorrhoids are usually painless because they are visually innervated. Inner hemorrhoids are usually painless because they are visually innervated. The 4 centimeter long anal canal illustrated in, okay, this figure I wanted to show actually. What else I'll do, I have a book, PDF of a book. I'll share the PDF with you in the group. So go for more detailed understanding of what the skin and what the nerves and this kind of sensations. You can, what are the nerves, which is like all this somatic, they are connected with the somatic pathway. So you can understand more deeper around this internal mucosal layer and internal area. Okay, and why we are having more pain. So this, if I'll just read this line, the epithelium from the dentate line to the intersphincteric groove is called anoderm. And this is similar to the skin, but without the skin appendages such as hair or sweat glands. It is innervated by lower hemorrhoidal nerve, which belongs to the somatic nerve system. Therefore, it is sensitive to pain. So this is upper part of the area. This particular part is very sensitive to pain. It has an important sensory function, important for the sphincteric action, internal sphincteric action. Even a weak stimulus causes a reflex contraction of the external sphincter. The anal fissures, other issues like the patient is having fissures, if the patient is having a fistulas, those are some kind of lacerations, they can always create irritation or some kind of burning sensation or painful sensation to this soft, hypersensitive skin. The distal part of this groove, the downward part of the groove, is made up with the normal skin. We don't have that high endoderm epithelium is present into the downward part. And we have a hair also present into this particular part. We have a sebaceous glands, we have a sweat gland, we have apocrine glands present into all this part. That's why it is also very soft at that area. We don't have dryness because of the presence of these glands over here. So glands are present everywhere, but more glands are more functional inside because of more vascularity. And glands are also functional downwards, which will keep providing us some kind of softening and moisture around our orifice. Because these glands, these areas, they are canals. And canals' main function is to expand whenever required. Stool has to pass through the whole canal. So we need some kind of moisture inside throughout. We don't want dry skin. If they will have more moisture, good vascularity, good glandular secretion, mucus secretion, so there will be better elasticity also into the whole canal. If the glands are not functional, the mucosa is not there, skin is dry, so it will give difficulty for the person during this passing of the stool downward during defecation. It might create an irritation and some kind of, they might feel the skin is kind of lacration kind of feeling and stretching kind of pain patient can feel. So that's why, we always believe in whenever in a female, when we're talking about the female body, so these particular glands are under the effect of hormones. So whenever we have estrogen hormones, better estrogen is there, so the glands will be more functional. So whenever the like lactating mothers, they feel more kind of dryness around that area because of the lack of estrogen in that particular stage. So they might feel those kind of stretching pain and dryness. That's why we are always believing in sitz bath during postnatal time period. So we try to give them sitz bath heating, and so the blood supply can be maintained. So sitz bath is very important after even any surgery, whenever any surgery happened to the hemorrhoids, removal of the hemorrhoids or the piles or any fistula corrections or this some kind of lacration, what we are saying, the fissure corrective surgeries. So after that, the glands are damaged, the vessels are damaged, the arteries are damaged. They got damaged, isn't it? Because they create some kind of compressions, constrictions, and the blood supply is altered. So just to improve that blood supply, and then you can understand the mucosa will be not that good and wetness is the dryness will be more in those kind of patients. So we have to improve that by giving heating to that particular area as a physiotherapist. Or either if inflammation is there, we might take a help from cryotherapy in initial time period, acute stages. And as soon as the inflammation will subside, we have to take a help from hot water packs and hot fermentation and sitz bath. They are very highly recommended after this kind of surgeries. Even application of IRR, these are important for our patient. Hot water fermentation, they're very important. We understand that when we understood the conditions. So this particular line, you can understand here. So this is the anal canal, which is starting. And in this anal canal, sorry, not this one. Sorry. Yep. So this is the anal canal, which is starting from here. This is the anoderm part, and this is the anal canal, which is starting. Okay, so this is very, very sensitive, this particular area. And this is the pectineal line. And now what can happen into this particular anal region? You might have heard about fissures, you might have heard about fistula, or you might have heard about piles. What is the difference between these things and how it can affect a person defecation? So we will understand that tomorrow, is it? Because it's already time is. So I don't want to finish it in a hurry because it's very, very important topic. And hemorrhoids also, the piles is like the same thing, hemorrhoids, internal and external hemorrhoids. So we'll start from this slide tomorrow. And then after this slide, there will be pelvic floor muscles. We are going to start.
Perfect.
Thank you.
So, yeah, that was really, really very informative and